Say full. It's a nice problem to have.
Yeah.
Ready?
Yeah.
All right.
Tell them the doors will be locked now so they stay.
Good evening. Welcome to our September board meeting. Such a wonderful crowd.
Yeah.
We're going to call to order open session. And David, if you could read us out of the actions taken in closed session.
Sure, certainly. The board considered 4 items in closed session this evening. The first 5.1 closed session minutes was approved on a 5-0 vote. There was no reportable action on item 5.2. And item 5.3 and 5.4, 5.3 was approved on a 5-0 vote, medical staff credentialing. And 5.4, that quality report was also received and approved on a 5-0 vote. And that concludes my report.
Thank you, sir. Item 9, do we have any deletions or corrections to the posted agenda? I'll start with board first.
I have none.
Hearing none. Any from the audience? Seeing none. Moving to item 10, audience input for items not on the agenda.
And none of you are going to speak?
Wow.
Well, you'll get your chance for every agenda item, so this was just for items not on the agenda. Input from Employee Association. Do you have anyone here from Employee Association? Hearing and seeing none. Moving on. Item 12, President and CEO monthly highlights. Anna, welcome. Thank you.
Thank you. Am I on or off right now? On. Okay, good. Sarah, you're pulling up my slides. I'm actually going to sort of sprint through these because actually I'm going to be up here twice tonight. We're going to talk about the True North a little bit later. But I just wanted to start by saying, as always, you can find the full reports of the administrative team on the website. We have the links there on the agenda. I want to start with a really wonderful recognition of a amazing person, Marie Kluge, who actually, if you were here last Friday, was it last Friday? It feels last Friday.
Yeah.
This is really just, Marie has, as you know, she is our latest recipient of the Spirit of Giving Award, and I just wanted to acknowledge it. She has done 20 years of volunteer service here, among other places that she's volunteered in our community, but here with us at Tahoe Forest. I also want to recognize that she now joins an elite group of community members who have really risen to the occasion to make a massive change in our community and in our health system. So she is the latest recipient of the Tom and Pam Hobday Spirit of Giving Award. We actually had the ceremony in the lobby because Marie really wanted the residents of the ECC to join. And it was, I don't know how many people were in, but as we talk about, there's a lot of people tonight in the room, and they were like, well, there's a lot of people, fire code. There was a lot of people in the lobby that night. Like you couldn't, there were people outside. There were so many people. It was so much fun. And I do want to recognize Pam Hobday, who I think is here. I saw her. Who and Ted Owens, who beautifully, had beautiful remarks to present this award. She was so honored, and but truly, it was our honor to be with her that night and to really recognize her service. So I just wanted to start off our night tonight by recognizing Marie. I'm not going to read these to you. I'm just going to say that I've pulled some key highlights out of the reports. A couple of things that have happened is we have launched a very scoped, and it will be a very paced cochlear implant program. We are, I would say that it is a pilot program, so we are going to be evaluating it at regular points. So very excited to be in the position to be able to see if that program makes sense for this community. We're so lucky to have Dr. Hoff with us. I also want to take a moment to recognize our inpatient nursing staff who they are one of only 14 hospitals in California that got a 5-star HCAHPS rating. So congratulations, Jen, and to our nurses. I wanted to highlight Incline tonight and really to say that they have achieved a 33-minute door to needle time. That means when you walk in the door to the time you get the clot buster, the anticoagulant. That is a phenomenal. The goal is 60 minutes. So that is a phenomenal achievement. I'm sorry, what? Oh, a green. Dorothy is a green. Thank you, Dorothy. But that is a phenomenal achievement, and I just wanted to pull that out of the reports. Also, our local thrift stores have raised over $200,000 this year to support our hospice. We heard from Jim earlier in the summer, and that's just incredible work. And we know that they just turned over the entire summer merchandise for all the winter merchandise, and it's a really Herculean task that they do so. Also, that our Credible Mind digital mental health platform is launching October 1st. So keep an eye out for that. And then we have 3 new physicians joining us in October in sports medicine, telecardiology, and in our hospitalist program. So welcome to our new physicians. Hopefully they're one of the people that are watching tonight, and we're shouting you out. I wanted to talk, we're going to hear a little bit later today, a little bit later this evening about our community health needs assessment, and I'll come back to that. But I did want to say that we have had work underway, and this is our community health labs, and those are a series of common labs that we provide, and it's really a complete blood count. That's sort of your general sort of blood panel. It's also a metabolic panel and then some other common tests. And these are labs that we provide at a fixed rate. And I just want to say the light color green is last year, and this year is the bright green is this year. And we have served over 472 patients this year from January to August, and that is a 56% increase. And the reason that I have this here is because you're going to hear a little bit later tonight from Louis. It will be programs like this that we build on when we think about our affordability plan and pilot that we're going to be bringing. These are really important tools that we have out there, and these really provide a critical line of sight both for patients, but also for their providers. So this is, we want to see this number grow. And these are low-cost, walk up in some way or short notice sort of lab panels that you can get around, as you see around the district. There's Incline, Truckee, and then there's the combined. Here's my clicker. I also wanted to put our just MRIs. Again, this is just a shout out to Diagnostic Imaging, who we talked about some of the awards they got last month, but I just also wanted to say, again, these run charts, if you will, these represent a whole lot of hustle that's going on in diagnostic, and it's kind of hard to see. For people who don't look at run charts as a side gig like I do, but if you look into the left-hand side, the very top line there, that's our peak in August of 2020, for fiscal year 2026, or August of 25. So it's significantly higher than last August and the August before. And I think that again, that is reflective of, this is new terminology for me, but many people are telling me that the shoulder season is shorter and the busy season is longer. And so that may be a reflection of that. I don't know. I'm out of my competency level in Truckee lingo and mountain lingo, but I do think that we are seeing a rise across the outpatient system. And again, this is another, just one more data point that is showing sort of stratospheric growth. I couldn't really go through this talk without mentioning that we've had some big news, and in addition to the rest of the healthcare landscape changing, we talked about some of the policy coming out of Washington, D.C., as well as Sacramento, which are significant, and some of the largest changes in federal program and payment programs since really the inception of Medicaid. We also have local stuff going on. So you may have seen it, but Barton Health is now has a partnership with Cleveland Clinic. Dr. Evans and I went down to Barton a week or so ago to talk to the CEO and the CMO, just to kind of learn a little bit more. It's still taking shape, but I think their goal is to really elevate the care sort of at that south end of the lake, and keep care close to home, which, that resonates with us. And then more recently, last week, we heard that Renown Health has now entered into a joint venture with Kaiser Permanente. And I think more to learn about that, but I will say what we do know and what's been published is that Kaiser Permanente is really starting a venture, Kaiser Permanente Nevada, and one of the ways that will take shape in our region is that they are going to start assuming an acquisition or a takeover of Hometown Health. So they'll be basically, Hometown Health will transform into Kaiser Permanente Nevada. And Kaiser and Renown have a lot of, I think, plans. There will be, we may see some changes in the provider market because in Nevada, health plans can hire physicians directly. So we're going to keep a really close eye on that. I have been, trying to stay as close as I can to Dr. Erling. He's obviously super busy right now with probably managing lots of media inquiries. But I think, again, this is just here to say we continue to sort of see seismic shifts in the environmental landscape in healthcare. And part of this is to tee up to say, later tonight, we're going to talk to you about how we're going to greet those shifts. Finally, we're going to hear also from the Community Health Needs Assessment Team, but I just wanted to, for those who might not stay on all night long, I want to make sure everybody knows that tomorrow we'll be our Community Health Needs Assessment will be presented at the Truckee Town Hall from 9 o'clock in the morning till noon, and it is 10183 Truckee Airport Road. So it's at Town Hall. And so we hope to see you there. There's a lot of really interesting information, but we're also going to hear about that tonight for those who stay.
Anna, will that be broadcast or recorded?
I don't, it will be recorded. Yes.
Tonight.
Yes, and you're going to hear, I think, an abridged version of that tonight. They're going to and so that will also be recorded. So if you can just really dive deep into this. We also have the full report attached to this report tonight. So for those who really, really want to take some time to learn, because there's a lot of really interesting information. I will stop there and ask if anyone has any questions or comments.
Anyone? Before? Comments, questions?
I'll just make one comment for a few minutes or two. That first slide, I thought, just spoke so much of your highlights, of course, obviously with Maria and all her work, but the key highlights, just, understanding. I'm just grateful, I guess, for everyone here who works here and does this work, because just reading the note of someone having a, debilitating stroke with, half their body paralyzed, and knowing in 33 minutes this person from reading the notes, had a significant recovery. That's amazing. An incline. I mean, to serve our community in such a small, it's such a partnership of everyone together. And so I want to go, I think hearing about cochlear implants, I think, initially that people say, well, how many we're going to do? But I think it's, again, stating how great we're doing and getting these pilot programs to match what our community needs. The second one, I think, it reminds me of Noah Wiley when he received the award for the pit, thanking at the very end, like everyone who checks in and their shift's coming off. That's day-to-day nursing, and so thank you. I think that's truly amazing work. Again, and our volunteers, that's to our hospice care, to those that need it the most, and our digital team, basically our IT and engineerings, and then just, meeting what our community needs. So I just love that slide. So thank you.
I love it too.
Thank you.
No further comment.
No further comment. From the audience, any comments, questions? All right, again, this is just for discussion, no action needed. Item 13, Medical Staff Exec Committee. Dr. Koch, welcome back.
Thank you. I'm here to just review the policies that have been brought forth and reviewed by the Medical Executive Committee and approved by us and are here for your review and approval. And there are only 2 policies or procedures this evening for review, and both of them relate to nursing assistance with reviewing labs that are abnormal and establishing protocols for how to manage those. And one of them is for occupational health, and the other one is for the multi-specialty clinics. But both of them are defining more clearly what RNs are able to do and what they are not. And I can go into the specific details if you'd like, but that's the gist of it. Any questions on either of those policies?
But I think it's a great idea, the policy, because oftentimes patients are waiting to hear. And if the physician is too busy with other patients, to have the RN do it has really helped a lot of our patients.
I agree.
I just have one question. What is it? Does the policy have when they don't answer the phone? Does it include that? Because I understand you can always text, you always message, and yes, many people are very digitally connected and want to hear that. But is there a process for if you leave a message or if you leave a text and you don't get a reply?
So I don't know that that's written in this specific policy, but as a general rule, our policy is that they get 3 calls, and if they still haven't responded, the report gets routed to the provider to make a decision whether a letter gets written to them, like snail mail, or whether they feel comfortable with just a MyChart message if the patient is active, current, and recently in the MyChart portal, or whether they feel it can just be dropped and discussed at the next routine visit.
Thank you.
Any other comments, questions? No? From the audience, comments, questions? Seeing none, this is an item for action, looking for a motion to approve.
I'll move to approve the policy, I'll move to approve the medical staff executive committee consent agenda as presented.
I second.
Motion and a second. All in favor?
Aye.
Opposed? All right, approved 5-0. Thank you, Dr. Koch. All right, item 14, consent calendar. These are items expected to be routine and non-controversial, be acted upon without discussion. However, there is the opportunity to pull items if we do need to discuss them. So I'll start with the board. Any items on the consent calendar that we wish to pull?
Not I.
No. From staff or audience, any items to pull? No? All right. Again, looking for a motion then to approve the consent calendar.
So moved.
I'll second.
Motion and a second. All in favor?
Aye.
Aye.
Opposed? All right, approved 5-0. Thank you. All right, item 15, items for board action. We have 5 items tonight, 2 of them with substantial presentations that I am very excited about. Starting first, 15.1, Community Health Needs Assessment. Maria and Lizzie. Hello and welcome. Oh, and a special guest, Bruce.
Right here. Somebody's gonna have the unfortunate misfortune of stepping on my stuff all over. Who she wants to put it
And Sarah, this works to advance?
It works to advance and make sure the microphones are pressed down to turn on. And both of them can be on at the same time.
Okay, good evening. Thank you for having the opportunity to present our 2025, at least the highlights of our 2025 Community Health Needs Assessment. I'm Maria Martin. I'm Director of Community Health, and I'm joined with Lizzie Hennessy, Tahoe Forest Population Health Analyst, and Bruce Lockwood, Senior Vice President from Professional Research Consultants. And this is the firm that did our needs assessment. Okay, so I just wanted to start a little bit with kind of the why. We do a community health and needs assessment once every 3 years, and it's a really important tool for us to learn about the needs of our community, the health needs of our community. We know that the information that we get all the time in our patient record, the medical chart, does not really fully reflect the same health needs that our community is seeing. And so this population-based data is really impactful and important for us to look at as we're making decisions. As a small community health center, we have a responsibility to focus on health and not just healthcare. And we also need to be responsive to the underlying factors that are impacting the health for some of our community members. In the development of this assessment, there were a lot of voices from our community that assisted us. We had over 100 different partners that shared feedback on the development of the survey tool. And for our part, as a health system, we made sure that we included data points that our community partners have historically used for grant writing, for trending, benchmarking, and things that relate to the missions of their organizations. And then once we have presented this information, we've digested it, and we've analyzed it, our next step is to create a plan of action. And that's something that we're really looking forward to. It'll be a really collaborative process with our community. Great. So what are we going to learn today? This was our 5th Community Health Needs Assessment, and you will notice, if you've read any of the previous assessments, that there are some findings further reinforcing what we'd already identified as a priority area. However, there are new opportunities of need on which we can focus in addition to those we have historically been identifying. It's important to note that this assessment is a snapshot in time. We use validated survey questions that assure we are measuring what we want to measure to give us an accurate snapshot of time, but it is a snapshot in time. The benefit of using these validated questions is that we can see trending, which you will see when Bruce reports. And he's going to spend some time on the methodology to further reassure you that this is a really well-founded study and we can rely on the information that you're learning today. As you go through the data,
There are over 100 survey items that we incorporated. We're just skimming the surface here, but I do encourage you to notice that there are subpopulations in Truckee and North Tahoe that are experiencing far greater needs than other populations in our area. And you will see that with some wonderful color coding in the slides to come. Next slide. We cannot say this enough. Tomorrow is a much more detailed 60-minute presentation. And it's not only an opportunity to see the data, but more importantly, I know a lot of our community members are planning on attending, and we can hear what they are understanding in the data. We can hear where they want to drive action. The meeting tomorrow, it's not even, we're calling it a community forum, is the first step in shifting into action. This is the first step in prioritizing what our community sees as our needs and further developing this action plan that is officially called the Community Health Improvement Plan. And without further ado, I'm going to introduce Bruce Lockwood, who is joining us his first time to Truckee, but he has been supporting Barton Health System for many needs assessments. So he's familiar with our region and the similarity of our needs.
Absolutely. Thank you, Lizzie. Thank you, everyone. Good evening. That was a very good setup to what I want to do tonight and really just give you kind of an overview of some of the key things that came out of this assessment process. And as Lizzie mentioned, to start out with, I want to talk a little bit about how we went about collecting this data because it was a very robust process and a very well thought out process. And we pulled in information from multiple sources that I'll talk about on some of the slides today, including what we call secondary data, so existing data that's out there that you're probably familiar with from the census or public health data sets. I'll have some of that in there. It's important to note that a lot of times that's really only available at the county level. So it's a broader area than the Tahoe Forest Health System primary service area for some of those secondary data items. So I'll point those out as we go through the slides today. But we also did some primary research, so some research that we originated ourselves. And we did 2 surveys, and they were very different from one another, but we did one survey with what we call key informants. So those are community leaders, health providers, social service representatives, various types of people who work with different populations throughout the community who have kind of a global understanding of the needs of those populations. So we sent out an online survey. We got feedback from 61 such individuals throughout the community. So a really good sampling of the provider side of things. Now, a lot of what we heard from them was very qualitative. So we have extensive comments from them that we included in our reporting. We grouped those according to themes. Tonight, I really only have one slide that reflects what we learned from the key informant, but that full report that's I think the board has and that will be made public has a lot of that, has all of that information highlighted as well. Probably the cornerstone of this assessment, though, was a customized local survey that we did with residents themselves. And this mirrors a process that's been done in the community in past assessment cycles. But once again, we initiated a survey with residents. We stratified it by some of the markets so we can look at different geographies within the primary service area. We asked people really about their own health status, their experiences and their behaviors. So not so much their perceptions of things, but really what their experience. So we can then aggregate that and see what the community experience is. It was largely a phone survey, but we did have some internet component. And I want to give you a little bit more detail about that population survey, because this is such an important part of this. So altogether, we had a really respectable sample size of 676 surveys across what we're calling the primary service area. So these are the zip codes that form the primary service area of Tahoe Forest. And you can see that represented in the map here. It includes the Truckee zip code, also Incline Village zip codes, and then other PSA zip codes along the western part of the lake. And we'll be able to split out the data by those geographies as we go through so we can see if there's geographic differences as well. We also did an oversampling through some work with Sierra Community House to oversample individuals who are at the lower socioeconomic levels so that we have robust data that really shows the needs among that population as well. But we folded it into the data in a way that it is fully representative of the community as a whole, but we can also parse it out for these subpopulations, which is so important. As Lizzie mentioned, it was a long survey, over 100 items, but we had great participation. And what's most important in our sampling is what's represented in the chart that I just put up on screen. And without getting into too much depth, what this shows is those orange bars represent the percentage of different demographics in our primary service area as revealed through census data. So the percentage men, women, different age groups, income levels, race, ethnicity, et cetera. And the red bars represent those same percentages in our final survey sample. And you can see those bars are level across the board. So what that means is a sample that we surveyed ultimately looks like the population, and that's what allows us to then project those findings more broadly to the community as a whole. So now that we got that out of the way, I want to get into some of the information that we actually uncovered. And today, it's really just a smattering of some of the key findings, but I am going to focus largely on some of the needs that were identified. But I want to assure you there was a lot of good news that came out of this assessment as well. And I'm going to put this up on screen without reading any of this really, but just to show you the plethora of the indicators where we saw where this community fares better than the U.S. overall, and some areas where we're actually doing better than we were doing 3 years ago or 6 years ago. So for a lot of these areas, we're at a better starting point than Americans in general. For some of these things like primary care, routine medical care for adults, we've seen some improvements in things like binge drinking from some of the past assessments. So there is good news kind of throughout this whole assessment. That said, we did find needs. And there are needs even within some of these areas because we identified trends or disparities in the population that we want to highlight. So I promised you one slide from our key informant survey. And like I said, most of their survey was pretty open-ended. It was more like a focus group. But at the outset of that survey, we asked key informants to rank order some health issues and tell us whether they think each of those is a major problem, moderate problem, minor problem, or no problem at all in the Truckee-Tahoe area, or Tahoe area. And this is what they were most concerned about. So at the top of this chart here, with the greatest percentage in red, major problem perceptions, substance use, social determinants of health, which is a broad category, certainly, but particularly housing, mental health, those were clearly top concerns for that group of providers and community leaders. Access to care was also a significant concern for about more than a third said it's a major problem. Over half said it's a moderate problem in this community. So I wanted to put this up so you can kind of keep this in mind as we look through some of the other data that we collected, and you can see how it comports with those findings. So for the rest of the slides, I'm going to look at the survey data that we did for the community, and also some slides that we pulled in from secondary sources, existing data that's out there. And we're kind of going to go through these general categories: access, behavioral health, chronic disease, and then finishing up on the social drivers of health, which of course impact all of the above. So first, talking about access to health care. In our survey of residents, we had a series of questions where we identified what kind of insurance, if any, folks had to cover medical expenses. And for this chart, and just for this question, I'm looking at adults 18 to 64, so excluding the Medicare population, which we know should be eligible for Medicare coverage. But in the 18 to 64 population, 11.1% of adults in the primary service area zip codes that we showed on that map have no type of health insurance coverage whatsoever, either through government-sponsored insurance coverage, Medicaid, Medicare, or through private insurance that they get at work or their spouse's work or purchase on their own. And that percentage is fairly similar, you can see to the left, between Truckee and Klein Village and the other primary service area zip codes, fairly consistent across all of those. Pretty similar to what we see across the state of California. You can see I've marked here the percentage for Nevada. The same questions were asked in a statewide survey for Nevada, much higher percentage of uninsured throughout Nevada. But again, we're statistically similar to what we see nationally in this case. Now, over time, we can also look at what's been uncovered in past surveys asking about health insurance coverage. And this goes back to the first baseline survey that was done in 2011. And you can see we're in a much better place than we were at that time. And we made significant strides through much of the 2010s in reducing insurance coverage. But I will point out, we have seen a couple consecutive increases in that percentage in the last 2 survey cycles. So lower than certainly where we were 14, 15 years ago, but increasing slightly over the last 6. Or 8, I guess. We can also look at these survey indicators, or these survey question results, in how different segments of the survey sample responded. So this is the percentage of women who reported being uninsured, percentage of men, people of different age groups, income levels, race, ethnicity. And you can see I've highlighted some here, and these are ones that are statistically significant in comparison with the rest of the sample. So we see a higher percentage of men than women who are uninsured, much higher percentage of those at lower income levels. And for the purposes today, that very low income category is folks living below the federal poverty level, which is about $30,000 for a family of 4. Low income is between 100 up to 199% of the federal poverty level, which is roughly $60,000 for a family of 4. So you can see the very significant difference by income level. Also much, much higher among Hispanic or Latino residents than what we see among non-Hispanic, white, and other residents.
Excuse me, would you like questions or comments as you're going along, or would you like us to save it till the end?
I do have some time at the end, but I mean, if it's a point of clarification, if you want to ask, that'd be fine.
In this case, it's really just a comment. I think, given the cost of living in our area, that we should be looking, we should be including the mid to high income people as well.
And you can see we've bracketed over each of those bottom 2 rows,
Right.
that percentage for the below 200%, because that really is kind of the group. we
But
need
I'm
to
just
look
saying, I
at.
think the bracket should be carried over to one, from the 200 to the 300. I mean, I've seen that done in other organizations where the cost of living is high.
Yeah.
And certainly not even as high as it is here.
Yeah, for
If
sure.
they include that number as
And
well.
we do have flexibility in kind of reconfiguring those income levels in the data as well. Beyond insurance coverage, there's certainly a number of factors that can impact a person's ability to access care. And we had additional questions in our survey to address many of those. And so this represents responses from 7 different questions. And I'll kind of go through first several just to point out what they mean. So in that first one, for example, in our survey, we found that 32.6% of all adults that we surveyed said there was a time in the past year when they needed medical care, but they didn't get it because they couldn't get an appointment when they needed it. 19.9% didn't get medical care when they needed it because they couldn't find a doctor to see them. 13.6% didn't go to the doctor because of cost. 11.5% didn't go to the doctor because they couldn't get there during office hours. 7.9% didn't get a needed prescription because of the cost at some point in the past year. And down to 4.7% had trouble with transportation. 2.1% had trouble with language and cultural barriers. Now, in terms of changes over time, you can see we've noted the cost of prescriptions is a little bit higher than what we've seen in years past. In 2021, for example, it was about 4% who said they went without a prescription they needed because of the cost. My company does actually do a national survey, a random national survey with these same questions too, so we can see what these responses are among Americans overall. And you can see we're pretty on par for the first 2 barriers, those appointment availability and ability to find a doctor. we actually fare much better than the nation as a whole for those other factors like cost, hours, transportation. They do tend to be less impactful here than we see across the US. Another note that I've added to this is we also had a question about prescription stretching. And we found that about 8% of adults said that they've skipped prescriptions in the last year or stretched their prescriptions in order to make them last longer and save money. So if we take all of those barriers that we tested and roll those up into one number, it's this. 46.8% of adults in the primary service area encountered one or more of those barriers in the past year preventing their care. And if we look at how that spreads across the community, it's certainly not an equal experience. Women, younger adults, certainly those under 65, those at the lowest income levels, the lower two income levels, for example, Hispanic respondents, once again, much more likely to encounter those access barriers than others in the community. We also asked about oral health and receipt of dental care, found that about 3 out of 4 adults have been to a dentist or a dental clinic at some point in the past year for care. That's pretty on point with what we've seen in most past surveys, minus in 2017 we saw a notably higher response, but pretty similar to what we saw in 2021. But again, we see disparity in who's receiving that oral health care, with some pretty low percentages among those at those lower income levels in the middle there. Also younger adults, also those Hispanic or Latino respondents that we surveyed. We did also find that in the primary service area, dental insurance coverage was a little bit below what we see nationally. So that certainly contributes to the likelihood of receiving timely dental care. I want to share a few slides around behavioral health, including mental health and substance use issues. In our survey, we had questions about conditions that folks may have been diagnosed with. And for example, we found here 18.2%, so almost 1 out of 5 adults, telling us that they've been diagnosed at some time in the past by a medical professional as having some type of depressive disorder. So major depression, minor depression, dysthymia. That's fairly similar to what we saw in 2021, a little bit higher than what was found in a 2017 survey. It's well below what we see nationally, where it's about 30% with a diagnosis of depression. On the right, you can see a similar chart for diagnoses of anxiety-related issues. So in terms of things like anxiety and problems with emotions or stress, 17.4% of adults report having been diagnosed by a medical professional with an anxiety disorder. That too has increased since it was first asked in 2017. If we look,
I was going to give some context to that last one.
Sure.
I just want to point out in 2017, Tahoe Forest did not have a behavioral health department. We've long identified mental health need since the first needs assessment. In 2019, we secured a grant to integrate behavioral health into primary care, which we did. And in 2020, we embedded universal depression screening into our primary care clinics. So I like to say we've strived to identify mental health needs earlier, which may be helping to identify and diagnose people sooner, and perhaps that is impacting these numbers. But we really have strived to embed the identification of mental health needs earlier.
Do you make a distinction between situational depression versus clinical depression?
In this case, it's going to be self-reported by the respondent, and we asked really if they've ever been diagnosed with a depressive disorder by a medical professional. And the examples were minor depression, major depression, or dysthymia. So if they perceive that that's how they've been diagnosed, that would be how it was reported.
Okay.
So that's good context, Lizzie. The that kind of diagnostic inflation factor can be at play in some of these things. But we do see significant disparity as well. This is that same question around past diagnoses of anxiety disorder by different demographic characteristics. And we see some of those same demographic groups emerging as significant: women, younger adults, and certainly those at lower income levels more likely to report having a past diagnosis. Now, this chart is something that was taken from the existing data, from the public health data sets. So these are based on death certificate information. This is an example of the data that I mentioned is much broader geographically, so these represent entire counties. In this case, it's a combined Placer, Nevada, and then Washoe counties on the Nevada side. So it's a much broader geography. But in this case, this shows the number of suicide deaths expressed as a rate per 100,000 population, and that's so we can compare to the states and to the nation as a whole. So the rate for the 3-county area that we're using as a proxy for our local data, 18.7 per 100,000, is kind of somewhere between the state and the Nevada data. But it is notably higher, more than a 15 percentage difference between what we see for the state of California, also higher than what we see for the U.S. I do know that the Nevada side has historically had significantly high suicide rates as well, so that's probably playing some of it into this service area proxy as well.
Question,
Sure.
so that's all of Washoe County, if you look at these
All of
data? It
Placer,
is
Nevada, and Washoe.
Washoe
combined.
County.
Yeah.
Thank you.
These two are from those mortality data, but these represent rates of death, in this case, with alcohol as an underlying cause. So this includes any death where alcohol was noted as a contributing factor to that death. So it could be a motor vehicle accident where alcohol was at play, or it could be acute alcohol poisoning. So it's all alcohol-induced, alcohol-related deaths. And you can see, again, this is for the 3 counties combined, but the red line represents the local service area counties over the last roughly decade or so. And you can see that, much like we see statewide and nationally, and we are increasing, but actually historically high in comparison to both states and to the nation as a whole. We can look at something similar for deaths that have other drugs as a contributing factor. In this case, unintentional drug-induced mortality. So this is what you would colloquially call accidental overdoses. Again, the red line represents the 3 counties, Placer, Nevada, and Washoe. And we are once again seeing increases in these over the last roughly decade, tracking closer to what we see for the U.S., for the state of Nevada, higher than what we see for the state of California, though, throughout the duration of the last decade or so. If we look across all accidental deaths and look at what the causes of those accidental deaths were, the category called poisoning, which includes drug overdoses, is actually the biggest share of that pie. 46% of all accidental deaths are attributed to poisoning, including drug overdoses. More deaths than attributed to things like motor vehicle crashes and falls. And that's something that we've seen change over the last couple decades in this country, is that's taken over that #1 spot for unintentional deaths. We had some questions about usage. So we asked individuals about usage of substances. And, of course, we are asking people to self-report, but we have fairly stable findings for these types of questions. As Lizzie mentioned, these are validated questions that are used. And I wanted to share a couple things here. The first bar represents what we call excessive drinking. So this includes individuals who experienced episodes of binge drinking over the last month, meaning they've had 4 or more drinks on a given occasion for females, 5 or more per occasion for men, or they average a high number of drinks per day. Those folks are found to engage in what's called excessive drinking, and that's true for 23.9% of adults in the area. Nationally, it's actually higher, 34.3%. It's about a third of adults engaging in those kind of high-risk alcohol behaviors. Second, 18.9% reported using marijuana, cannabis, THC, hashish in the past month. So about 1 out of 5 adults. 2.6% acknowledged using an illicit drug in the past month, meaning an illegal street drug or using a prescription not prescribed to them. So that's about 2.6%. Nationally, that's higher at 8.4%. That's certainly something that is potentially underreported. But it's interesting that we do see folks still acknowledging those use of those substances. So if I interpret that correctly, where we see lower usage but higher death, kind of go back to the prior slide? Yeah, again, the geographies are a little bit different, so that's partly at play here. But higher excessive drinking or lower excessive drinking by that measure, yes, but higher alcohol-induced mortality. So. This question was one of the few questions in our survey that was largely perception-based, and it was really designed to gauge the broader effect that substance use has in people's lives. And we asked people to tell us the degree to which they feel their own life has been affected by someone's substance use, either their own or that of someone they love. And we found that 42.2% of adults said that their life has been impacted to some degree by substance use issues, either issues they're dealing with them or a family member or a friend. And that is actually a little bit lower than what we see nationally as well. A little bit higher than we see in the under 65 segment, certainly. Higher among non-Hispanic white than we see in the Hispanic segment that we surveyed. But really, I guess what I want to point out in this is that, you know, none of these segments is untouched by this issue. With the exception of a couple, you know, they're all about 40% or more reporting an impact of substance use in their life. In terms of chronic disease, you know, some of the things that we measured were, you know, leading causes of death. And certainly heart disease and cancer are always going to be top of mind because they are the number 1 and number 2 leading causes of death in the community. Stroke, which shares many of the same risk factors as heart disease, you know, contributes another 7.2% to those deaths. So together, that's about half of all deaths in the community. Unintentional injuries, again, a significant cause. Many of those are related to substance use. We also found a relatively high percentage of adults in our survey who said that they are themselves acting as a caregiver to a friend or a family member who is experiencing an ongoing or long-term health issue. So 27% of adults in the community are serving as a caregiver in some capacity, primarily for individuals who have dementia or cognitive impairment or maybe more temporary injuries or broken bones. Mental illness was also frequently mentioned as a reason for having to care for someone else. And you can see it's similarly high, no statistical difference between the 3 community segments that we looked at, but it is higher than what we see nationally. Oops. And then I want to close out talking about a couple social drivers of health. So these are the things the factors of our lives that are about where we live, how we live, that impact so much of our outcomes, our health outcomes. And two in particular I wanted to talk about were housing and food insecurity issues. Those really emerged as the most important components of this in the assessment. So for example, we add a question in the survey asking about what we call housing instability, asking people how often they worry about making that next rent or mortgage payment. And you can see that the experience here is quite different than it is nationally. 20% of adults say that they always, usually, or sometimes worry about paying rent or mortgage. Much lower than we see across the U.S. overall. Remained fairly consistent over time. By community, it was higher in those other PSA zip codes down along the western side of the lake than it was in Truckee or Incline Village. Different experience, though, certainly among different segments of our community. So although overall it's low compared to the nation as a whole, these segments have a much different experience. Women, young adults, certainly those at the lower income levels, Hispanic respondents, people who rent versus those who own or are purchasing their home, 3 times more likely to worry about making their rent payment than those who are more established or in a home owning situation. We had, in our survey, actually 3% of respondents tell us there was a time in the past year when they were unhoused, living in a car, in a shelter, living on the street. And that, although that percentage is relatively low to some of the other things that we found, I wanted to point out that it's higher in some of these segments, young adults, low income, Hispanic respondents. And if we translate that to the number of people that actually represents, we're talking about hundreds and hundreds of individuals in our community for whom homelessness and being unhoused is a recent, if not current, experience. And then I also wanted to share a question that we asked around food insecurity. There was a couple of questions we included that I think originate with the FDA, and they asked people how often did they worry about running out of food during the past year before they had money to buy more. And we found that about 1 out of 10 adults in the primary service area, 10.7%, said that that was a frequent worry for them over the course of the last year. Certainly well below what we see nationally. Nationally right now, it's about 40% of adults with food insecurity. But that 10.7% is significantly higher than we saw just a few short years ago. In 2021, we had, in the survey that was done, only 3% reported that same worry. So even though it's one where we look like we do so much better than the US, we've seen it slip a little in recent years. It was higher, again, in some of those other PSA zip codes down along the western side of the lake than we see in the Truckee and Incline zips. And of course, as you might expect, this is really concentrated in those lower income segments, not just those at the lowest incomes, but even those at that middle income, even up to twice the federal poverty level. We see significant shares reporting food insecurity. Very high among Hispanic respondents that took part in our survey. 38.9% reported this food insecurity by this measure. Higher generally in younger adults than we see in older adults as well. So with that, I wanted to see if there was any questions. Lizzie, Maureen, do you have anything to add?
Questions first?
Okay. Any questions?
Question, yeah, on food insecurity, we used to have the Project Mana, which I think is now folded into another organization.
See our community house.
Community house, yeah. So food is available, is it not? I mean, people don't go hungry if they have opportunities from church groups or the organization you just talked about there.
So I think that what we're going to be seeing over the next year or and on is with changes in funding at the federal level, social service agencies, especially Project Mana and their food security program, are really going to be hit by budget cuts to be able to purchase food for our community. And they've already seen a dramatic decrease in the availability of getting fresh produce, where they used to be able to get them through USDA grants and with local farmers. That money went away. They are also seeing an increase in need in our community of people that need food. They do have distributions, or on specific days of the week. In emergency situations, people can contact someone and they will bring them a bag, but it's not like every day there's a place you can go to get food.
Okay.
And you can imagine the barriers as our winter begins.
Yeah.
I have learned there's different questions for hunger. The two questions we used are part of a much longer 18-question survey, which we did not incorporate because we already had 100 survey items. But I have learned that you could be food insecure and reducing your meals, but not necessarily be hungry. And and having other behaviors so that you're not going hungry, but you are food insecure.
Yeah. What about Meals on Wheels, and how does that impact?
And that program is available here as well. It typically works with seniors or people who have just like been released from the hospital. As far as I know, that I haven't heard that they have reached capacity, so that is an option for some people.
Yeah.
Within food insecurity, is there any looking into, there's a difference between food quality and food insecurity. So you might have access to food, you might not be food insecure, but the food you are not insecure about might be really low quality food. Is there any questions around that?
We did have other questions about food. We
We
did have a question along those lines.
We had a question specific to access to fresh produce.
Yes.
So we do, that does, yeah. And that does speak to the, food quality piece of it. And I think there was also input from the key informants in a more qualitative way around, that issue as well.
Thank you.
My reaction to much of this information is that we're seeing the same problems, but the acuity of those problems has gone up dramatically. And it's just crying for some kind of intervention.
I have a question about the suicide mortality and I think alcohol-induced mortality trends, and because it includes those three counties, Washoe County, Nevada, and Placer. How can we look at that data? Is there any way to look at that data for our local area, or is that just hard? You compare anxiety and depression for our area, low, mortality high. So to me, it just seems, is that what I to interpret? Well, these are the three counties. I think this would be presented to leaders, and I'm thinking this tomorrow, okay, counties, we have to help this problem. This is a county-wide issue versus what does a health system bring to that? I'm just struggling with that. Is there anything that I should be looking at or thinking about that, or is that kind of the right way to look at that?
No, those type of data really just aren't available at that granular level for a couple of reasons. One is because, county is the government level at which those things are reported. Reports up to the county and up to the state and then up to the CDC nation. Also, because counts for things like suicide are relatively low, which is a good thing. If you get too granular, even looking at one of those counties individual, a lot of times they'll suppress the data, because once it gets to a certain count level and below, they suppress the data for anonymity purposes. So we're limited in that way as well.
I can speak a little more to this. We are aware of local needs related to suicide. That is why in 2013, we launched an interdisciplinary suicide prevention coalition that includes the school district and Truckee PD and Speedy Foundation and Placer, Nevada County and Sierra Mental Wellness Group, a lot of people. We further launched the health system-centric Zero Suicide in 2019. And again, we embedded universal depression screening, which has a suicidal ideation question the last 2 weeks into every primary care adult visit. So while it's challenging to have specific data for our zip codes due to the sensitivity of that topic, we have really strong partnerships that we have very sensitive conversations because postvention is prevention. And we really have this collaborative nature embedded within these coalitions to address what we know is a need, even if we don't fully feel this rate at the county level, especially if 3 counties is fully reflective of our zip code rate.
Nor does it.
I'll just say real quick, normally we'll go through board question comments and then go to audience, but since this is a discussion about community, it might be more appropriate. If you do have questions or comments, maybe be a little more engaging and interactive here as opposed to us and them in comments and questions. So feel free to step up during this conversation. Sorry, I didn't want to cut you off, but.
I just had a question with regard to the suicide data that we were just talking about. And it doesn't appear to be broken down at all by age. And I know that was an issue in our community a few years ago. And I wonder if there's been any update to any of that data.
Usually the data we get at the county level is 2 years behind. So it is publicly available online, but it is a rate per 100,000. So I haven't looked at those numbers lately, but I can share that we have used those numbers to secure federal grant funding because of our numbers historically. Yeah.
Is there any survey that also looks at pediatric data? Because this is 18 to 64.
Yeah. Do you want to ask the Jonathan?
Yeah, so we did have questions around, we had a limited set of questions for households that had also had a child, and we had a series of questions about a randomly selected child in that household. So there is child-related data in the overall assessment. I didn't highlight any of it tonight, but there is some of that there.
And then I can also add, we actually did a few qualitative focus groups, one of which was with the school district, and that they partner with our community collaborative Tahoe Truckee, and I was able to further collaborate with Dr. Kramer, and we have incorporated the findings and the overall themes that emerged from that youth focus group. These were youth voices at this youth forum that the school district does every year, and you will see those at the very end in the focus group section. We also did a focus group for our Spanish-speaking community members in partnership with Sierra Community House in Kings Beach, and we did one at the senior center. So there is some more qualitative data in addition to the key informant surveys.
I've got one question about the unintentional drug-induced mortality trends.
Mm-hmm.
Do you consider it a behavioral change, or is it because of the advent of fentanyl?
I mean, largely, naturally, it's been the advent of fentanyl in recent years that has really accelerated those deaths. Now, as Lisa mentioned, that's another one that's a couple years behind. So we have to keep that in mind too as we look at those data. There's a couple years lag time to that.
Yeah.
In terms of our own responsiveness to that, we do have addiction medicine clinic, which is on the newer side. And with the Suicide Prevention Coalition and the County of Nevada No Overdose organization, there's been more education around harm reduction. So take on how to use Narcan to prevent a fatality. And then the third one in that area is we do drug take-back events, and also our pharmacy and the Truckee PD has drop boxes where you can get rid of prescription medicines that you don't need so that they don't fall into the hands of someone and might be misused.
The sheriff's office in Tahoe City also.
Yep.
Without making any assumptions, when you're looking at just observation of the data, it was not uncommon to see if there was a higher percentage for low income, the Hispanic percent would mirror that. Within the data, though, is it possible to parse out, is it a cultural driver or a financial driver when we see those two bars?
Yeah, I mean, we
mirroring
could
each other?
cross-tabulate both. We could look at that Hispanic segment at different income levels, see if there are differences even within that subset. I mean, we have a lot of opportunity to drill down into the data. The limit is, getting to a sample size that's too small to be meaningful. But we do have access to the data. Tahoe Forest has access to that data that, at any time you can drill down into those survey findings and look at it in different ways and combine things like that.
Wonderful, thank you.
Yeah.
We just have one last slide. Some really what stood out to us being community health. Food insecurity, we just spent a lot of time talking about food insecurity and just that it's increased across the board. I think we've spent enough time talking about that you all hopefully will see that as standing out as well. Obviously, the impact on our socioeconomically disadvantaged community members is a theme throughout this. And I want to point out that's not a new theme. We have seen this in every needs assessment that we've done. And then Maria, you go to the last one.
Yeah, and then the last thing that's really important is that a lot of the impact on our results is beyond us. It really has to do with policy changes at this federal and the state level. One of our huge successes this year was the slides that relate to access to insurance. And we saw dramatic improvements to people having insurance across all income levels. And along with that we saw an increase in people seeing a primary care provider. And so that was a huge success for us. But with the current policies and the reductions in people's access to different types of insurance, subsidies for people that are paying on their own, we anticipate that we're going to see that just turn right back down. And the other things, the kind of the climate of fear and mistrust or maybe being afraid to access care is going to lead to people maybe not using our services as frequently as would be best for them for managing their conditions, and they're going to be coming in with much more severe cases. And then I mentioned earlier the problems with the financing for our safety net organizations in our community. They are experiencing this decrease in funding as well, and we're going to need to be able to respond to that.
Wonderful. Any other comments, questions?
No, I look forward to the presentation tomorrow as well. I think this was very informative to get the community feedback. Will be, I think, very important.
Okay. Thank you.
Not off the
One
hook
more
yet.
time.
Not off the hook yet, Quick check to the audience. Any final comments, questions before we? All right. A closing comment that I have is, I don't know the right words. Is it wonderful, refreshing to see that in many instances we're well below national averages on metrics, which I think is good, but it doesn't mean we don't have a lot of work to do still, right? Because I don't think the national average is a great benchmark for us to measure ourselves against. With that, thank you. This is an item for action, however, not to approve, but to accept. So we'd be looking for a motion to accept the report as presented.
I wouldn't move to accept the report as presented.
I'll second that.
Motion and second. All in favor?
Aye.
Opposed? All right, accepted 5-0. Thank you so much.
Thank you.
And we'll
We'll
see
see you
everyone tomorrow.
tomorrow.
We're going to keep plugging. See everyone tomorrow at the community presentation. All right, next item, 15.2, True North update and annual goals. Anna, are you going to lead us into that?
I am.
Fantastic.
I'm going to kind of change seats a little bit because I'm going to be joined by some of my colleagues. Can we all drive our own, or? Kim doesn't trust us. Okay, Kim's gonna drive. Don't switch my slide till I go like this. Switch. No. While everybody's getting seated, I just want to say like how lovely it is to see so many people here with us tonight, and for those who are tuned in now, and for those who may tune in at a later time, we're really glad to be able to have this conversation with you. I'm Anna Roth, and I'm the president and CEO of Tahoe Forest Hospital District, and I'm delighted to be here tonight. I want to start by thanking our board of directors for your leadership and your commitment. You've been incredibly generous with your time and knowledge since I've arrived. I have passed my 6-month point now, so I can't call myself a newbie anymore. I also want to thank the Tahoe Forest team, everyone on the team. From the moment I have arrived, they've been welcoming, thoughtful, generous with their ideas, clear about what they love the most about this system, and very generous about some hopes and dreams they have for the system. I'm so delighted that we have members of our community here tonight, and I hope many are tuning in. I just want to thank you so much for being here, for offering your partnership, for really walking alongside us for so long. It's been a really hard year, and we are so grateful you're with us. You are central to everything that we're going to be discussing tonight. I want to acknowledge the Administrative Council, that's our leadership team, and their guidance that has helped us get where we are tonight. And I'd also like to give very special thanks to Farhad Islam and Dylan Crosby. Dylan wasn't able to be here. Farhad is here. I know he's here. I saw him. They have really been helping to facilitate this subgroup of leaders. And it's probably been, I mean, I won't put words in their mouth, but it might have been like herding cats. But they've been at the table with us week in and week out. As we gather here tonight, we're going to talk about what we're calling the True North. And this is not a replacement for our strategy, but rather a way to build on the strategy. In our vision, this reflects our shared horizon. It is grounded in the needs of our community, the resilience of our people, and the possibilities that we can all create together. And I think we need to really work on that. That was a sobering needs assessment, though there was some really good news. I think there's a lot of calls to action for all of us. We're going to begin tonight's discussion. I mean, this is going to be a little bit different than maybe you're used to. I mean, I think I actually spent about a year watching you all via YouTube, and it's going to be a little different. You're going to see a team of us talk, not just one person. And in fact, this is my only slide, I think. I actually have one more. But you're going to first hear from our Chief Operating Officer, Louis Ward, and he's going to present this year's goals. Many of these are rooted in the extraordinary work of our staff, and many will be familiar to you. But some will be actually a little bit different than you've seen in the past. They may feel a little bit more process-oriented. They may feel a little like vague, and that's by design, because these are really essential in the steps we're going to take to make sure that those goals, take shape, not because of what leadership says, but because of what we all say as a collective, as a community. We're going to define those together. We have some starting points, but this is not finished. This will really take us forward into the recommendations that we'll be bringing this coming June. That's why we're calling this year, 2026, 2025 and 2026, the year of planning and alignment. Once Louis presents our goals, then Crystal Felix, our Chief Financial Officer, and Dr. Evans, our Chief Medical Officer, also guardian of science, will reflect on where we've been and where we're headed. Dr. Evans also is going to importantly talk a little bit about the how we're going to get there, because there's a lot of ideas here, but actually when it really comes down to what separates sort of those great systems versus good systems is the great systems know how to get it done. And so Dr. Evans is going to talk a little bit about that. And then finally, our Chief Administrative Officer, Kim McCarl, is going to walk us through our plan to do this work in partnership with all of you, with the community, with our team members, and with our board. We want to assure you that even though this is a year of planning and alignment, that the incredible care and service that happens here it will continue without any pause. So again, that's why a lot of these measures you'll hear Louis talk about are going to be familiar, because we don't get to stop. I'll use the analogy, we're going to continue building the plane while flying it. So we're going to continue to pay close attention to measures that matter: patient experience, physician alignment, staff engagement, and much more data that shows impact. But just as importantly, we're going to keep listening. So listening is actually something that isn't really measured, but it's really important. We want to listen to our staff. We want to listen to our community, to the people who rely on us for care. So there will be deep listening going on too. We're going to return often to this board. We're going to bring you updates, refine our approach. We're going to ensure success is defined together by the people who we serve and the people in our community, as well as the people who deliver our care. So again, I just want to set the tone to say some of this might feel vague. That's because we don't feel that we can actually properly define all of this without all of you, and that takes time. I want to leave you, as you sort of listen to the slides tonight, that tonight this won't be the final word, but the beginning of a conversation. And for me, as someone, I'm just going to take one last moment to call myself someone who's still seeing things with new eyes here. And really so far, since I've been here, the conversations that I've had with everyone have been so valuable on really how kind of this has began to take shape. But as we take this path, we will shape the true north together. I just want to talk really quickly, end with 3 themes that have been rising to the top. These are for discussion, but not decisions. Okay, we're calling them, and you're going to hear more about them tonight, health within reach, and that includes the broad definition of health, which includes addressing hunger and safe housing. Right? Peaks of excellence and transformation. You're going to hear a lot more about that, and we hope this is an invitation for you to be involved with us to help really refine these concepts and really move forward together. We're deliberately building the community's voice into everything that we do, recognizing that our true north is dependent and will only emerge through listening, collaboration, and commitment to moving forward together. So with that, I'm going to hand over to Louis.
Well, very good. Good evening, Chair McGarry, Board of Directors, all of you who are spending your time and your evening with us tonight here in the room, and the thousands watching from home.
The 5,000 you're going to engage with?
I do believe we may have more viewers than normal, so that's great.
Slide, Anna?
Yes, sorry. You can
Yeah.
slide. Sorry, I'm not in charge of the slides.
You know, I do want to just start by echoing Anna's commitment to this board, this community, that the amazing work that happens every single day here at Tahoe Forest will continue even while we have a year of listening, designing, planning, and aligning. So again, as Anna mentioned, you will see some familiar goals, but you will see some new goals here that really commit ourselves to listening to the communities that we serve. Want to start with community. So right at the top, we aim to engage with 5,000 people to shape our community priorities. We have a number of people here in the crowd, so we're already doing well. Ultimately, we did just hear from our community health needs assessments. We heard the community health needs assessment presentation, and that really sets us up for our community health improvement plan next. But tomorrow will be a great opportunity to hear from our community in terms of what matters to them, and that will inform us moving forward. So I am very confident, even though 5,000 seems like a very aspirational number, we are very confident that we can get there. So, Crystal Felix says that is the floor. So 5,000 or greater, no doubt. I do want to just stop and mention the Community Health Improvement Plan. That is going to be informing us on how we need to move forward in terms of what the needs of the community are and our action items when we hear from the community. But we are going to make a very purposeful effort to include environmental stewardship in that effort also. We've heard many times from many members of our community that have joined us here in public comment, and this is greatly important to them and all throughout the communities that we serve. So this will be a core tenet of what we'll be focusing on and listening to over this next year. Moving to service, we know that access to healthcare is the major priority for this community and for all of our North Lake communities that we serve. We intend to bring down our third next available appointments to less than 30 days in our primary care setting, which will include pediatrics and women's health. We know that there's a lot of work to do in this space. We want to set an achievable target for our teams and our providers that care so deeply about these patients, and we continue to keep moving those numbers down. So if we do hit 30 days or less, it will in fact be the best numbers that we've seen in the last few years. So this is an aspirational goal. We also aim to achieve a bronze level geriatric emergency department accreditation. More familiar to the community might be an age-friendly emergency room. I'm seeing thumbs up there. Of course, we have an aging population, and this is going to be very important in the years to come. So Dr. Gladman, Dr. Evans, there's a number of physicians that have come, and they're really going to champion this effort. So that'll be very much part of the next year's work. We want to ensure that we sustain our top decile patient satisfaction scores. We all know that we are in rarefied air in terms of our patient satisfaction scores here at Tahoe Forest Health System. All to do, and the credit goes to the staff that we have here and our providers here. But clearly, that is something very important to our community and something we are extremely proud of. So we will be focusing on that as we continue our journey of listening to others, but it will be a core tenet of all of our conversations as we move into this next year. With regards to quality, clearly is at the root of everything we do here. We seek to achieve greater than 90% compliance with 9 quality star rating bundle measurements that actually include safe opioid use in 6 of those measures. So Dr. Evans will, questions can go to Dr. Evans on exactly what the goal is there when we get to the Q&A. In terms of people, I mean, people is, none of this is possible without the great team here at Tahoe Forest Health System. So clearly we want them to be as much involved with our true north as the communities that we serve. So we want to engage 750 of our employees and our team members. That might sound like a low number, but that is a significant percentage of the team here at Tahoe Forest Health System. And we do actually have some very creative ideas in terms of how we can lightly engage without just kind of survey fatigue that we've heard of. But we're really excited about engaging with our team here at Tahoe Forest, because really we want them to assist us in a recruitment and a retention strategy. We want to hear from them what meaningful engagement is, right? We want to listen and hear from our employees over this next year, and it will inform not only our true north, but also each activities that happen here each and every day. And in terms of finance, clearly we need to be a stable financial organization to achieve this year's goals, as well as really deliver on what we hear from our community. And so maintaining 188 days cash on hand by the end of the fiscal year is a target that we've placed. And lastly, we seek to achieve, we have heard from the community already in terms of affordability, and we just saw a community health needs assessment that clearly points out many metrics that involve concerns over affordability, whether it's healthcare or housing needs. So we look to ourselves and the community really think creatively on how we can launch an affordability pilot in the outpatient laboratory for the communities that we serve. So we are very excited about all of this work. And together, these goals, they represent our commitment to aligning today's Tahoe Forest Health System with what will become the community's true north vision for Tahoe Forest Health System, defined by the community and for the communities that we serve. And with that, I will pass it to Crystal Felix, and she will go into a little bit more about our community.
Good evening, Crystal Felix, Chief Financial Officer. I feel pretty honored to be able to speak to the next few slides that we have for you tonight. Anna might be the new eyes. I feel like I might be the old eyes. Approaching 23 years with the health system and actually being part and seeing some of these things come to fruition. And maybe I'm finally approaching enough years that I can be considered a local, because I know that's pretty tough to do in this area. We should never forget what Tahoe Forest Health System is all about and how it started. And truly, it was by the community, for the community. This organization started back in 1949. The community wanted it. It was built on philanthropy as well as community drive. And in 1949, the district was formed by the members of this community. And we were built upon the land that Dick Joseph donated. And it's very unfortunate that that came from a loss, a very dear loss for him, which was his wife and his son during childbirth, that there was no healthcare facility here for them to go to. And so that was the driving force to get Tahoe Forest started. And the hospital opened in '52. We heard from the Incline community how important it was for them to have health care. That facility closed several times over the years until we acquired it in '96. And then, of course, Measure C, huge for this community. Thank you, thank you, thank you for passing that measure and being willing to fund the $98.5 million that went towards things we heard the community wanted. We asked, and therefore we built. The Cancer Center was built with that, the expansion of the emergency department, surgical services, our ECC. And then, of course, in 2012, we were proudly able to open the Gene Upshaw Memorial Tahoe Forest Cancer Center. Huge, huge milestone. And all of this was built upon the voice of the community, the interactions with the community, the philanthropy of the community. I mean, you're going to hear these themes over and over again. I heard Anna start also saying we're gathered here today, and it really made me think about a wedding. And I would say this is probably the opportunity for us to really say we're renewing our vows to this community, to hear their voice and what they want. So as we've said, we planned over this next year, we really want to engage, listen, learn, really have participants from all in the new True North, not really new, but it could be new, the True North that we're headed towards. So with that, if we could go to the next slide. Whoops, there's Pam. So, of course, what we do here is purely driven by the community, and we have some great models that we can talk about where that's come true. And of course, the Gene Upshaw Cancer Center is one of them. I was blessed to be here when this started, and it all started really from letters from patients in our local community going, please, is there something the local hospital can do to provide cancer care to our patients? And from that, with some great leadership and community involvement, there was a lot of conversation of could this happen? And it was just grabbed to and evolved in an amazing way. What started out as a very small ability to do some chemotherapy then turned into several community members coming together, actually using their own money and time and flying to 8 different areas across the United States to really look at what is great cancer care. And their feedback is what came back to this organization and informed us of this is what we should do. And then based upon that, we also had the community that said, we want that, we will pass Measure C, and we will help you build that. And so that was all community. And it really came from the strength behind really wanting something and us able to make it come to fruition. I believe through the voice of the community, we will hear other areas in which they believe we should have additional models or peaks of excellence within this health system. And I can't wait to hear the ideas that come forth in that. Let's go to the next slide.
I believe that a huge strength of Tahoe Forest Health System is being able to utilize the community as a think tank and a collaborative partnership in building amazing projects on this campus.
So that was Pam Hobday, and she is one of several people who put up their own time and money to really help us create that cancer center. So thank you, Pam. Our community, our strength, what can I say? You hear this more and more nowadays, you know, we the people, right? We the people have a voice. And it is we the people of our community, the patients we serve, the people that visit us, all have a voice. And so this is where we really need to hear those voices helping us define what our priorities need to be, how we can create trust that this is the place to come. And honestly, we want to measure that improvement. And if we can't measure it, shame on us. We should be able to demonstrate what we're doing that really is impacting the community based upon the needs. We've already seen some of those needs tonight. We are going to turn some of that, the voices and the ideas, connecting them with data to then take action. And what we do needs to be sustainable, and it will be the next step in where we go. And so listening to we the people will be mission critical as we move forward in the True North.
Born in this hospital, my wife has had surgeries in this hospital, I've had my share of stitches. I just can't say enough about how convenient the care is here and how great the care is. It's amazing. We don't have to drive down the hill for an emergency, and I think that's really rare. I think a lot of people don't know all that this hospital and this healthcare system offers until they need it.
Mm-hmm. That was Breck overall. He's actually the chair of one of our foundations as well. So we appreciate Breck taking the time to make that video. Our next slide, I'm going to tag team with Dr. Evans, Health Within Reach. And this is really not us saying what that is. This is about us asking a lot of questions about what does that mean to you? Does that mean, like we already talked about, more affordable labs? Is this about insurance products? Is this about prescriptions? You know, what does health mean to you? And so we are certainly not prescribing what that is, but we'll definitely take the opportunity to ask you a million questions to find out what that is. And I'm going to go ahead and let you chime in if you'd like.
Yeah, thank you for teeing that up. You know, I think that I'll just remind you guys on the goals slide, we looked at the third next available as an annual goal, which is a metric we've looked at quite a bit and worked on quite a bit for the last couple of years. It's a good example, though, of how it's easy to simplify something like what does access to care mean for our community. I think I've made assumptions about what it means to have good access to care. But I think we now, looking at it with a broader perspective, certainly after the community health needs assessment, access to care is complex. And if you ask a lot of people what it means to have good access to care, you're going to get a lot of different answers. Certainly, Crystal touched on financial issues. If you cannot afford care, that's an access problem.
a lot of people do come up to us, in the grocery store, and they'll say, I can't get in to see my doctor. And so we can kind of simplify that down to third next available. But that's just a reflection of how long does it take for routine or chronic care management for a visit for those patients. And there's lots of other metrics that we could be looking at, lots of other things. One thing we do very well that we don't want to lose sight of is same-day care. We do great same-day care when people have sort of an urgent issue like a sore throat or something like that. We have outstanding access in the urgent care. We have great post-hospitalization discharge follow-up, that sort of thing. But there are absolutely areas where we do not have good access to care. I also want to think about other things maybe we don't always consider, like our geography. So, we have the mountains, we have the lake, we have weather, we have a lot of construction issues. We're not Bakersfield, so we have to think about our geography a little bit different. We're not Bakersfield, right? No. Yeah. I was just fact checking that. So, we got to think about our geography. So some of our patients, that might be their biggest actual barrier to getting good access to care is where they are. We do need to think about things like what are our coverage hours? Do we need to extend our hours? Do we need to do more weekend stuff? We've done some of that. We've done some extension. Do we need to use technology more to improve access to care? Is telemedicine going to be a solution for many of our patients? I know if I ask my daughters, they would probably prefer to have a telemedicine visit on their phone than to go in and see somebody. That's not the case for me. I don't know that it's the case for our whole community. We need to find out to what degree that's going to be a solution for us. Do we need to start thinking about mobile clinics more? Lots of communities have done that. We haven't really dabbled with that too much. So I agree with Anna's approach to this, that we really do need to stop assuming what access looks like and just get out there and find out what it means for our community. Next slide.
Has grown, but so has Truckee and the surrounding area of Tahoe, and it just keeps growing and growing. And just bridging that gap between the growth of the community size-wise and the demand and the services and the ability to provide healthcare, it'd be great just to see that narrow. I think it's a challenge everywhere, but here we have such a great healthcare system. I'd just love to see it be more available to more.
Thank you, Breck. I think that was him skiing too, covering up the powder maybe. Maybe that was Dale. It might have been Dale.
Yeah, I was thinking that same thing.
Yeah, probably. So we want to talk about peaks of excellence, and I'll just say, the word excellence, that's one of our core values. Quality is one of our peak focus areas. And when you talk to our employees, certainly when you talk to our providers, excellence is a big reason why a lot of people are here. And it attracts more people who really want to be part of something outstanding. And we do a lot of things very, very well. We certainly, I think we provide excellent care throughout the organization, but then there are some areas that are highlights. Certainly the Cancer Center we've talked about is an amazing program. We have outstanding orthopedics, sports medicine, diagnostic imaging. We're now a a level 3 trauma center. So there's excellence all around. But the question is, what else might we consider doing? Where else could we put some energy, put some resources? And I'd like to really know what people in the community have to say about that. Some people have already been bringing up what they'd like to see. I'll just point out that there's 24 kind of general specialties out there in healthcare now. Anybody want to guess how many subspecialties now exist in the United States? It's 130. Wow. 130. And, my intent is to get all of them here in Truckee. I don't know if Anna and Crystal are in favor of that. But we'll find out. It might take a while. Yeah. So we probably need to really figure out what is the most important things we should be doing around centers of excellence. One thing does kind of keep surfacing, and I think you've maybe got a video on that one.
See a more truly cohesive orthopedics and sports performance center. Kind of like our cancer center and all of its interconnected and how it serves our community and how awesome it is. We have all the pieces here for our orthopedics. We have the best physical therapists, we have the best orthopedic surgeons, all of that best sports medicine doctors. I would love to see more of a holistic center for them all to truly work in synergy for all of the, pro athletes, recreational athletes, the lifestyle that we have up here. I just think that would be such a great asset to our community.
And I will second that motion. All in favor? I'm just kidding. So yeah, there's definitely a lot of interest. There's been interest in that for quite some time, obviously, and I think it's something we need to strongly consider doing. Want to talk a little bit about transformation, which is a word and a subject that we've been talking about a lot since Anna arrived. And really, what does it mean to be an organization that puts transformation first? And I would just say that it is not enough to solve the problems of the day, complex as they are. I've been in healthcare for almost 30 years, and there has never been a time when we haven't been facing one crisis or another. And I think that you could focus on the crisis at hand, and we do need to solve today's problems. But what we really need to do is make sure that we are becoming experts in solving future problems and becoming change experts and process improvement experts and leadership development experts, and really make sure that we're adept, because we can't predict what's coming down the line next. And there's been some really wild stuff recently. So we do need to think about this a little bit differently. And there is a science to change management. There is a science to process improvement. And we've actually done quite a bit already in this organization, so I'm not saying we're starting from scratch, but we do have things that we can learn. Last month, you guys heard from a team that actually traveled up to NUCA. They came back with a lot of enthusiasm. They came back with a lot of really good ideas about what's going on up in NUCA in southern Alaska. And NUCA is an outstanding organization. They do wonderful things. We are not going to carbon copy NUCA and become that here. What we want to do is learn from organizations like that and apply them to our community and our problems and become better as a result of that. And we need to learn from others as well. Next month, another group is going to be going up to Virginia Mason up in Seattle, which some of you probably are well aware that Virginia Mason has been on a multi-decade journey with process improvement using lean principles based on the Toyota production system. And they've done some incredible things. Again, we're not going to be Virginia Mason. We're going to be Tahoe Forest, and we're going to learn from these things. I do want to say, some of the things we do around leadership development are already amazing. I think you guys have seen a couple of times probably presentations on our PEAK program, which Damara Stone put together. It's amazing what we're doing there. We want to amplify those types of activities here, and we just want to become better and better as we go. So that's about it on transformation. Let me just check the list. I think I got it. You got to run more videos.
Very supported. I just love it. I feel like I have all the resources that I need, and I can be successful. And I'm very proud of working here.
Me too. Yes, me too. It's a great organization, and I'm just glad to have the support of the board with all these changes that we're looking to do. And I'm really excited about this year and what we're going to learn from over 5,000 people in our community. Thank you.
All right. We are going to talk a little bit about community engagement. And of course, we've talked about this quite a bit already in this presentation. However, we're going to narrow down a little bit in terms of what we plan to do and when we plan to do it by. But I really want to call your attention to a couple of our statements that are up here, really exploring what community ownership means. I think we need to better understand that. Obviously, each of our residents in the communities that we serve have a sense of ownership of this health system. As you heard from Crystal, it goes back generations, and so we need to lean into that, as that is where historically the best ideas that we have had have come from. So we will be really leaning into listening to our community and really thinking about that through the lens of they are owners in this community. And then in terms of trust, really building trust through transparent, collaborative discussions and leadership, really convening people to come together in settings where they can be transparent and feel a sense of collaboration with health system leadership, our providers, and all of our staff. So we are eager to get to this work. I believe this work has really already started in some ways. But again, we will do one more plug for the Community Health Needs Assessment that will be tomorrow. But, Dr. Evans actually just made a comment that we often use in somewhat of a joking fashion, that when we're in the grocery store, people come up to us and they talk about their medical needs or their access, and I'm sure our providers have had lots of conversations in the grocery store. So who knows? You might see us in the grocery store, right? We might have to get a table, and we may actually just say, here we are, come talk to us. We absolutely intend to move around the community in ways that we have not in the past. And so we're eager. On October 3rd, we will be out at the Truckee High School homecoming game, where we intend to learn some from our community. I'll make a plug, go Wolverines. But we will do the same thing actually in Tahoe City with the Lakers. So just things that we intend to do over this next year that we're really eager to get to that work. And I will say, as we move into these next slides, just be thinking about this, right? Meeting people where they are, not where we expect them to come. And I will pass it over to our administrative officer, Kim.
All right, well, thank you so much. We wanted to reflect to you how broadly we're thinking about how we'll go about getting this input. It's not going to be by chance. It's certainly going to be a strategic thought that we put into it. I hope that you will look at this list up here and you will see one thing that you think to yourself, oh gosh, I really would not want to do that. And then you look up and you see one thing that says, well, that would meet my needs, because that means we're broad enough that we're hopefully reaching a little bit of everybody. I think it is so appropriate and so wonderful that the community health needs assessment went right before us, because I think we can use them as a model for how to go about doing this, right? We can get in-person input, we can get digital input, we can work through our partners. In fact, we've already engaged with some local experts who've done this across other organizations in town who are giving us very good advice and very good thoughts about how to go about doing it. The 5,000 people number actually came from them. It's some of the work that they've done in the past really led to that kind of input. And so it's ambitious, but we didn't really pull it out of thin air. It's based on some experience that we've seen in the community before. So we want to hear from everybody. And one thing that I should say is when we talk about 5,000 voices or 5,000 different touches of engagement, there will be different types of engagement and different levels of engagement, and we will track those. So for instance, when we go to the homecoming game, there will be a QR code on the giveaways that we have that lead people to a small survey that asks a question or two about their experience in Tahoe Forest, and then asks them to volunteer for a committee if they are so engaged. So we will count how many QR codes we give out, and then we will count how many people fill out the survey. Two very different things, but still tracking input or still tracking a touch, right? So we will be very deliberate in how we track the way that we do this and what the input means to us and how we use it. So here we're getting down to the nitty-gritty, and we want you to be super clear that we are thinking about this in a way that keeps us moving forward. This is concrete work for us. As Louis mentioned, there are some bolded points under the first column that are things that are already underway. So, for instance, tomorrow morning, a letter will go out to all of our staff members that will give an overview of tonight's presentation and invite them to participate in a town hall meeting where they can get basically this same presentation and have the same opportunity for input, because we think that's so vitally important that we not stop here. The QR code we talked about at the homecoming game. At the event tomorrow, there will be another QR code where people can volunteer to be part of a Peaks of Excellence committee. So we are not waiting until next month even. We are starting tomorrow in terms of getting this input. Already we know partners, already we have relationships, and we will build on all of those. We really are thinking strategically about how we do this. So you all know better than I do that there are second homeowners in our community that come up here over the holidays. So traditionally, we would not do public outreach during the holidays, but here we really realize that's an opportunity to hear from those homeowners, and that's important to us. Mm-hmm. So we'll figure out over the holidays how we reach them and how we hear from them. I do want to point out that you will get an initial sort of set of results in March, because one of the things we really want to do is make sure that we align this input with our budgeting process. I think we all understand, as Crystal nods her head. We do really understand that this is a commitment. This is something that we're really saying we will do, and we're going to put some money behind it. So what does that look like? But then we will come back to you as a strong commitment with a True North plan in June and ask for your approval of that. By then, I think you will be tired of hearing the word community. I used to have a speech professor who would count how many times you said the word Now we're going to start counting the number of times we say the word community, because it's important, but we feel like we can't say it enough times. So some detail here, and I will say much, much more to come. And as I turn it back over to Anna, I'm just going to remind her about shoes.
Yeah, I got it. I didn't forget. But thank you, Kim. So I think what you heard is you heard a beginning, really a laying of the groundwork. These are seeds. We know that the sunshine and the water is really coming from our staff, from our community, from the people we serve and the people who rely on us. So you will see, I just want to set expectations that when we come back in June, you may see some departures from what you saw tonight, something different. I don't know exactly what you see, but what I can guarantee you is it will be much better than what we came up with, because as great as the leadership team is here, which is one of the greatest, honestly, it's such an honor to work with our leadership team. We really know that the community and our workforce is really what makes us so special and so unique. So you will see, I think, many sort of refined ideas and maybe even some different ideas. I want to go to our next slide, and it's really a quote from our board chair. And I love this quote because he has been asking this question since I met him. And I think it's an important question, and it goes along with both the True North and I think our sort of the possibilities and aspirations for our community and our system. And it also goes along with the discussion we heard just before this in the community health needs assessment. And that's really about, what does it really mean to us? What does it mean to go beyond creating care to actually creating health, right? What does it mean for a health system to step into the burden and responsibility and accountability to create and be the center of health in a community? What does that look like? And I think the True North process is going to get us closer to that. It might not answer that because that's a really big question. I was always hoping when he was asking that question, it's like, you don't think I have the answer to that, right? But I mean, what does it mean when you're living in a community where food insecurity, Farhad probably already did the math, but in my head, it's like a 246% increase. Okay, that's big. That's huge. What does it mean when you talk about health within reach? That goes beyond affordability and access, right? That's also about how are we going to really address the fact that there are people in our community that are disproportionately burdened. I know people do. I don't know if we still use the word anymore, equity, but that's what that is. That's inequity, operationalized. How do we find those people who are at risk? And that changes over time, right? We saw in the COVID pandemic, that was the elderly were disproportionately hit, as well as the low income, right, communities of color. But we don't know what that at risk is going to look like 5 years from now, which is really what Dr. Evans was talking about. How do we have an infrastructure that can solve problems and that can build capability to improve, right? How do we become the best at getting better? This is really the questions that we're asking ourselves. What makes this place unique, really, for me, and again, it's not only the care that we provide, but it's really the skill and spirit of the people here and of this community. It's extraordinary. It's an extraordinary place. I think Louis talked about rarefied air in terms of the patient experience scores, but we have rarefied air everywhere up here. It's amazing. This is a community that, in my assessment, again, with my still new eyes. Almost aged, not quite as aged as my friend Crystal here. But this is a community that has always led from the front. Always. You'll notice tonight that several of the leaders, I think most of the leaders and many of the frontline staff, but we're wearing tennis shoes tonight. Yeah. We're doing that because we need to keep up with our community and we need to keep up with our workforce. Right? They're way ahead of us and we have some work to do. So you might actually see me wearing tennis shoes a lot more. Dr. Koch approves. But we got to get out there and we got to get going and we need to listen and we need to learn from our community and from our staff. And we know that the vision as it takes shape, it's not going to come from a single voice, it's going to come from all of us as a collective. Somebody talked about, Louie talked about community ownership. I'm doing a little reflections here. Because I had no slides, so I'm still taking my time. Because I'm not giving the microphone back to Dr. Evans yet. But, Louie talked about community ownership. And I will say, I just want to say again, if I may, as a sort of a new person, the power distribution has been a little bit off kilter here. And we really, as a leadership system here, we are going to redistribute it back out to our workers and back out to our community. That is our intention this year. That is by design. We are not abdicating our responsibility. This is our responsibility. And I think I just want to say thank you to everybody for giving me just a little bit of time and giving us a little time tonight to talk with you about kind of what we sort of see as what's possible for our community, right? We know that we are so grateful for the ideas already and the generosity that we've run into, the tenacity of this team. And I just want to thank you for putting your trust in us as a leadership system, and as well as on behalf of Tahoe Forest Health System for the people who rely on this system and come to us for service, and the people who are watching that come to us for service. We're really grateful for your trust, and we're going to work hard to continue to earn that trust and keep that trust. That concludes our final remarks. We're happy to take any questions, comments, any major challenges. Go to Dr. Evans or Crystal. And later on, if you like, we could stay late and renew our vows. Yeah. And by the way, we're not going to leave any time for anybody who has any concerns to speak up about that because it's already happening. But thank you so much for the time. Back to the chair.
Thank you. Well, let me start with the board as far as any comments or questions.
Oh, I am speechless. No, I am so inspired.
Yeah.
Not only because this is such a wonderful aspiration, but because there's an action plan behind it. Yeah. And not only is it a possibility, given this team that you just heard tonight, it's a probability. And not only will they do what they have said, they will probably exceed those expectations. And I'm sticking around. This is going to be fun. So yeah, those are my thoughts. Thank you. Thank you. Each of you, thank you.
Well, I'm just going to echo Mary's comments. I think the presentation tonight has really energized. I think it energized this whole group that we are on a path, and it's the path to transformation, and that is what our community needs. And I think that we've been in a good place a long time, but it isn't the best place we can be. So again, we're sticking around, and we're watching all of you to make sure that you're helping us do this and you're giving us your input. I think we've got our leadership team, we're in good hands to make this happen, but we do have to support them. This isn't going to be easy. I mean, this is change, and change doesn't come overnight. and it gets really tiring day after day. So please, please, please be with us, be behind our board, help support them, especially as we go into the community. The community isn't used to hearing us. They barely see us on TV. I don't think our Nielsen ratings have been up at all this year. So again, if you can support in your words or in your volunteerism, we would love that. So thank you, and we're behind you 100%.
Wow, you gotta back that up, I'm next? All right.
You can put Dale next if you want.
Yeah, Dale, you're up. I'm struck by a lot of terms. I mean, thank you, really. That was exceptional, and, my comments, there's a few things that struck me, by the community, for the community. Well, thank you. That's really, a year of planning in partnership. Year. I'm a very impatient person, so I had to really write that down. A year.
I think we're at 9 months now.
Yeah, well, that was my pivot. You got my next part. Our community is our strength. We have work to do. So, I was reflecting, I was like, gosh, 5,000. I was like, a year ago, I think I was in front of Kings Beach and Tahoe City making intros. So let me tell you, Kings Beach and Tahoe City Post Office, you want 5,000? You got a lot of pointed feedback there. And one of them was the Costa Lab. So it's so heartening to hear already that you're listening to the community, already. I know that there's a lot planning. Again, patient, 9 months. I like that, the 9 months. But you've already listened to the community, so thank you. And so, I'll only end with, I look at my reflection as a board member. How can we support you? How can we be in partnership with the community? I'm not a big fan of meetings, so I'm going to call out, please, less meetings and not a lot of committees. But I look forward to this. This has been so exciting. I look forward to more exciting board meetings so we can hear the data. You guys already built dashboards. We've seen them once, so that's already built, and I agree. This is the team that will do it. I have complete confidence, and I'm just excited for the next meeting, so thank you.
I'd like to expand a little bit on the subject of listening, and I hearken back to the listening that went on when we developed our cancer center. We sent that team around, and they picked up all these ideas. I've never been one to reinvent the wheel, The wheel's been invented already. We need to talk to, and I'm encouraged by the fact that we went to Alaska to listen to them, and you're planning on another trip to Washington. The subject, in my 12 years on the board, the most frequent grocery store line comment I've had is either A, I can't get an appointment with my primary care doctor, or B, I've got to go down to Reno Diagnostics to get my lab work or to get my digital imaging. Why can't you guys make it cheaper? Perhaps somebody solved that problem, and maybe we can find out by asking the right people and the right questions. Because that seems to be a ubiquitous type of problem. Joshua Christ, how we listen to the Mayo Clinic and how they developed their dyad working relationship and how it's affected our hospital. So I hope listening goes far beyond just listening to our patients and community, but we listen to some other successful hospitals and how they're doing the thing, so we don't, as I say, have to reinvent the wheel. So,
can I just comment? I think the listening to other centers of excellence and places around the world is going to be a big part of this. And then I think at some point people will be coming here to listen to us and what we've been doing, right? Tahoe is a place that people come to for restorative, health and to get their mental health and their emotional health and their physical health back. And I think they're going to want to come and find out what we've been doing and what our secret sauce is. So there'll be field trips here.
Fantastic. So no questions. A lot of comments. Thank you.
What are we going to do it capacity-wise? Do we have the capacity to do? I mean, when I look at this, I think, wow, we're going to be doing community, we're going to be doing classes, we're going to be doing patient care. So do we have that capacity to do it? And that would be something that I would question.
There's two answers to that, yes and no.
Yeah.
So we have a lot of things that are already happening, and in some cases, we'll be reorganizing those, and I don't mean reorganizational structure thing. I mean coupling them together in different ways, maybe doing some sense making around the programs that already exist. But there will be, I think, Crystal might have said it, or Kim might have said it, I can't remember. We're definitely going to have to, we're lining this up with budget purposefully, because we do believe that we will need to make investments. So we don't have everything we need, but we will be able to articulate and budget, put a budget up against that as we go. That is part of, I think, what, as we go forward, let's say the peaks of excellence, when we bring that plan, that will come with a cost, right? And then a plan for that. And that will be all Crystal's job. But I mean, I do want to say it was in one of the slides, but I do want to say we will also leverage the abundance that already exists. There is a lot. There is a lot.
Fantastic. Well, let me turn to the audience. Yeah, if you can, and just make sure the mic's on. There's the red button. Yeah, introduce yourself, make sure the mic's on.
I think I'm on. Nina Winans, I'm a sports medicine doc in town, and I've been here for about 31 years. So I've seen this community come and build stuff before. So this is, thank you. This is such a different time to be at this podium than last time I was here. And thank you, everybody, for making this transition happen. It's amazing. It's so inspiring. And I wore some really silly shoes, but they are Merrell's, and I can freaking run in them. But my new colleague, who's taken over running a lot of our outreach programs in the community, Dr. Kari Rizak, who you'll maybe hear from next, is wearing sensible running shoes. She does an amazing talk about footwear. So that's for another time. But I just want to say, let's dream and plan at a very high level. We already have an advantage because we're already at 6,500 feet, so 50,000 is just not that high. And we want to do it the best way it possibly can be. And the only way we can do that is to engage our community. And look, I mean, who shows up for a board meeting, on their own time? Well, our community does, and I think tomorrow morning you'll probably see a lot of the same people and a bunch of other people too. So I am a sports medicine doctor, and I was involved in our Orthopedic Advisory Council, which was basically structured from the same way that we built our cancer center. It was a collaboration of community members, physicians, clinicians, and administration, and we did a lot of this same stuff that was just discussed about the cancer center. We did outreach, we went, did benchmarking, we have so as far as you said, Dale, of not reinventing the wheel, we have some blueprints, we have some research that's already been done for us to move forward with an orthopedic and sports medicine center of excellence. Thank you, Alicia Barr, for teeing that up. And to me, it's not, sports medicine to me, and I think to a lot of us in this room, is really not all about, the professional athletes, but we all want the kind of care that the professional athletes get. And we want to really capitalize on the free stuff that we have in our community, the trees and the lakes and the mountains that we have, and to make that more accessible to our entire community. So one of the other hats that I wear is I'm on the board of directors for Truckee Trails Foundation, and that's one of our missions of making this community more walkable and rideable, and to expand those trails and to expand that to many different user groups that we maybe haven't reached. So I think there's some room for the same kind of thoughts of looking at how do we reach all the different user groups. We just met with High Fives Foundation today, our adaptive athletes. And one of my missions when I retire is to learn Spanish. I speak 5 languages that are, English is pretty useful, the rest of them are not so much, unless anyone else speaks Norwegian here. But anyway, the idea of an orthopedic sports medicine center for excellence is all-encompassing. It really is this comprehensive look that we want to try to move towards. And we've already been working not just on what we did on the OAC, but what we've been doing within the orthopedic surgery department with innovations and surgeries, and Dr. Dodd bringing to really the entire region here the anterior approach and hip replacement. You know, he was really at the forefront of that, and some of the newer stuff that Kari Rizak will tell you about that we're doing with tendon treatment of all those pesky overuse injuries, and also tying this in with education and research and being really a target area for people to come and train. I mean, we have the perfect altitude for a lot of this kind of, special both training and fitness testing and doing something with it. So that's, I think, coming back to that, the things that we really have here that are kind of free to all, but maybe not as accessible to some other user groups than many of us in this room, is, our trees, our lakes, our mountains. That really is sort of our power that we have. So let's capitalize on it. I can't wait to hear what our community has to say and where this goes. It's amazing. Thank you.
Thank you.
I guess she kind of teed me up, so I guess go. So I'm Kari Rizak. I am the new sports medicine doc who came in almost a year ago to the date. And so my perspective is not going to be historical. Obviously, I'm not a newbie, newish. But that being said, I was like, okay, sure, this cool new facility would be great, but does the community need it? And I honestly have to say, you guys kind of gave me a softball. Whoever made this presentation, fantastic. Because even when we saw the skier, and it was could have been Dale, could have been anybody in this room. And it's that is the community. Anybody hiking, that is who we see every single day. And honestly, the fact that we see these pictures and we don't even think twice about it, that's our community. Every single person is an athlete. What's interesting about that is all our patients come in who are professional athletes. And to be fair, I grew up in Wichita, Kansas, and I remember my math teacher, my calculus teacher, he had a sign on there that said 1 in 40 million will be professional athletes, so do your homework, which is good because I'm glad I did it. I think that ratio is probably much higher here in Truckee, which is great, but that also means we have a really high professional athlete community. We have a very high para-athlete community, but we also have these athletes who come into my room and they'll be I'm having this thing. I know I'm not sports. I probably shouldn't be in here. But then they'll be but I also walked 14 miles uphill one way this weekend for fun. And it's hiking is an athlete too. So even the people who feel they're not athletes are athletes in this community. And I would say my most sedentary patient this week, even she, I think, is an athlete in a different way. She doesn't do sports. She's sedentary for other medical reasons, but she does knit. And she was I have to keep knitting, my poor hands. And she was knitting because she was making blankets for people in the hospital. Oh. So I know, this community, I tell you what. So that's just a normal day. And so I think from my perspective, it's everybody in this community is an athlete and everybody would benefit from these services. I can help the professional athlete with their thumb, and I can help the knitter with their thumb. And everybody benefits from kind of the Center for Excellence for Athletics because that is the community that we're in. And yeah, that's it. Thank you.
Thank you. I'm sure ESPN does have a channel with competitive knitting.
Yeah.
Absolutely. Yeah.
Hi,
Pam,
Pam
good to see you.
Hobday. I just want to say congratulations.
Yeah.
What a difference 6 months makes.
Yeah.
What a team. Congratulations to the board. Let's just all. This is from the community. This is just amazing. I want to piggyback on what Nina talked about and just give a little bit of historical data because we miss it sometimes, Crystal. Thank you. So we walked into the Cancer Center in 2012. 1 month later, we replicated the Cancer Advisory Council 1 month later and started the Orthopedic Advisory Council. So we had 14 different community leaders, none of which were on the Cancer Advisory Council, because they all had different skill sets. And when you talk about what makes this different, this community different, is the Cancer Advisory Council felt equal with staff. And we had experts from all different areas. As you were thinking about Dale and reflecting back, we had many entrepreneurs who had started businesses. Poor Crystal had to put up with some people who thought they knew business modeling better than she did. She was amazing. But there's so much in this community. And the difference is, as Anna, you were talking about, it's allowing a collaborative partnership where obviously it's called advisory for a purpose. But that Orthopedic Advisory Council met for 4 years, and we benchmarked. And every single community member on that committee did the same thing as we did with the Cancer Advisory Council. Everyone paid for themselves, traveling to 8 different facilities. So there was so much work that was done. And I have every minute of every meeting at your disposal. I have lots of data, but we need that Orthopedic Center of Excellence. And let's build on that. A lot of things have changed, but thank you. And that's only one idea. And I can't wait for tomorrow. And this is a new day for our community. And I just want to celebrate. Thank you.
So Pam, I just have to let you know, I still have a big fat folder of
Yeah.
all that work.
You do too.
Yeah, I took all the minutes.
So Dr. Joy Koch and
Dr. Josh Kreis. We just want to take a minute to thank everyone who listened to us. You're all extremely capable listeners, and I think we all see what's possible when we listen to each other. So thank you for doing that, and thank you to the Dales of the world and the Pams of the world, to the Dr. Evans of the world, to the Nina Winans of the world. We are in a much better place, and I want to extend a special thanks to my dear friend and colleague Joy, who was the first to ask to be listened to. So with that.
I actually was brought to tears by the presentation tonight. It just felt like such a profound change for our medical community and our whole community. And I just really, really felt that change tonight. I could feel the way you, as the C-suite, had really worked to make this presentation be meaningful and express the change you're envisioning. I could envision that change with you, and it felt fabulous. And I want to really thank the board because you did listen to us, and I was a part of the nominating committee and the selection committee for the new CEO, and I feel like you all ought to be really proud of yourselves for the job you did in that regard. Yeah. I also have just one small story to tell that Dr. Evans actually started the story out, but he didn't tell the story tonight. There was a gentleman who came into our emergency room with a condition and ended up spending a night in the hospital. And as a result of that, he interacted with our emergency room doctors. Then he interacted with our hospitalists. Then he needed a rapid hospital follow-up, and he was, given one of our primary care providers to see in follow-up. And I had the privilege of speaking to him the other night because it turns out that he's a specialist that we don't have in our community who has moved here and wasn't planning on practicing medicine up here, but is now seriously considering it as a result of the phenomenally positive interactions he had with every single person that he met. Not just physicians, but also the nursing staff, the team members that scheduled his appointments, all of the team that contributed to his experience. And his most awe-filled comment was, where I come from, you can't even call and make an appointment to get a primary care provider no matter how long you're willing to wait. Thank you.
Hi, everyone. Megan Shirley. I'm a PA working here at the health system, longtime local, and population health medical director. And I would echo the excitement about hearing the approach and the desire to listen and then act upon what you're hearing. As a frontline worker with my tennies on, and I didn't get tipped off, I just want to, just a word of unease or caution that, and I'm glad you brought up the word capacity. I am out there seeing patients, and there are a lot of things we need to work on in our current system and our current structure. And I just urge the leadership team to remember that work that still we need to do now, while we're still building, of course, and getting better, but really giving the resources to us that are doing the jobs to help us do our jobs the best we can and keep us feeling fulfilled, so that we want to keep practicing. Thank you.
The next slide, they're going to start giving out our tennis shoes.
Hi there, my name is Jason Toops. I don't work in healthcare, so new face for many of you, I hope. I'm actually a planning commissioner in the town of Truckee, and I wanted to come today because I heard there was rumblings of something exciting, and I just want to say how inspiring this report was. Going back to the community and really listening to what they have to say is so important and so inspiring and such a important reminder. And I want to say that from the town point of view, I hope we can learn from what you guys learned, because so much of, we have to work together, right? I think the hospital is the largest employer in our community. So you're both a huge community unto yourselves and also a huge part of the entire Truckee community. And also we have to work together on things. We just heard about all the social determinants of health, like housing, that aren't going to be solved just in this room, right? Where we have to work together across town government and the other government organizations that we have here to address those problems. So I'm super excited. I can't wait to hear what you learn. Like, I didn't quite see it, but wherever we can get more information back out to the community as you're digesting it, I would love to learn about that. And I guess we at the town will get our running shoes on as well, so we can keep up with you. Thank you.
And sir, you're welcome to come to any of our board meetings.
I will be doing that, yes.
Wow. Any others? Wonderful. Well, thank you for all the comments. I had jotted down some notes during the presentation of what I thought were witty and insightful closing comments, but they pale in comparison to what we've heard. So I'll spare you on that. But just a reminder that this is a journey, so there'll be plenty of opportunity for me to wax poetic in the months ahead. But I couldn't be more excited about what we heard, about the changes we've made. These were tough decisions for a board. A colleague of mine who was a senior executive at a well-known large national health system, I shared with him some of what was going on a few years ago and shared some of the performance of the organization and said, I think we might have to contemplate a leadership change. And he said, are you crazy? Like, that's an incredible health system you just described. And so to make change, to take that on when things on the surface look really, really good, does require listening. You do have to dig deeper. And so I thank everyone with the courage to stand up and speak over the past few years. And for those willing to listen, I think we're heading in a good direction. and I can't be more excited about the True North. So thank you. All right.
May I make a motion to approve the True North update and annual goals?
I would be happy to second it.
All right, we have a motion and a second. All in favor?
Aye.
Opposed? All right. Thank you, everyone.
We're not done yet. We got to go to the library. We got the library yet to deal with.
Data hard score and line.
Yeah.
We have beta yet to go through.
Yeah.
Thank you.
Nina. Yes,
Yeah.
yes.
So, yeah.
And I hope you'll stick around and be a part of it.
Well,
I know you will.
all I can say is, wow.
Oh,
I can't remember a meeting
When
like
is
this
it?
in my 12 years.
oh, you're another one. There's a bunch of people retiring.
Everything positive.
If I can just, I'm checking the clock. We have 3 more items on the agenda, so I do want to just chip away. We probably should have put these other agenda items maybe in front of the last presentation, but we do have some business to address here. Item 15.3, Beta Heart validation and culture of patient safety score action plans. Ashley Davis is the name I have here. Thank you, and welcome.
Can you hear me? Is that on? Perfect. Those are like really tough acts to follow.
You don't have to try and bring tears to the audience or anything. Yeah, I mean, just
I was surprised that everybody walked out after that one, but thank you for staying. For those who are, and thank you all for the time tonight. I'm Ashley Davis. I'm the patient safety officer for the organization, the health system. And we're going to shift focus just a little bit from talking about community to the people that are taking care of the community and a little bit how we're going to do that. So I am not only the patient safety officer, I'm a nurse here, also the lead of our Beta Heart program. So we're going to just do a quick little summary overview of our activities the last year and our culture of safety survey. So for those of you not familiar with the Beta Heart program, Beta is our liability insurer. We've partnered with them for a very, very long time. They put on the HEART program, so that stands for Healing, Empathy, Accountability, Resolution, and Trust. And that essentially is our culture of safety framework, the guidelines that we use to help take care of patients, especially during adverse events. We recognize that adverse events not only affect the patients and their families, but also the staff here at the hospital taking care of them. So this program allows us to respond to those events proactively with open communication, compassion, and system changes when we realize something has gone wrong. So the HEART program, this is a lot of information on this slide, but essentially it's 5 domains. Culture of safety includes our culture of safety survey. That is something that we give annually to the staff, which I'll go into more detail here coming up. We talk about identification of adverse events with rapid events response and analysis, meaning as soon as something happens, we want to jump on that quickly, start investigating, and support the staff involved. Not only support the staff, but support the families involved. Part of that includes the next domain, which is communication and transparency. We want to be as open and honest as we can with everybody involved, because that helps establish trust. If we're not talking to people, they think we're hiding something. They can tell when we're lying, so being honest is great. That goes with staff too. When something happens with a staff member, if they don't hear from us, they assume they're getting fired. Which is rarely the case. So we try to also not only be open and transparent, we identify opportunities for peer support, care for the caregiver. That's one of our domains. So we have a really robust peer support program, which I am super proud of, and I could talk about that for hours, but I won't. And then also our early resolution. So after an adverse event, we want the family and the people involved to have some closure, and that looks different to every single person. So we partner with Beta and the family to figure out what resolution looks like to them. Sometimes it's just a conversation, sometimes it's being part of an action plan, sometimes it's monetary, it all depends. And so we really want that family to feel like we took care of them and handled the situation appropriately. Just very, very high level summary of the events from the HEART program this last year. Our SCORE Culture of Safety survey had a 74% response rate, which is well above and beyond the 60% threshold that BETA recommends for good data. Which we're going to learn a little bit more about that coming up here in a few slides. We are still promoting actively event reporting, speaking up when you see something, say something, giving staff the feeling that they can speak up without fear of retaliation. Using just culture and high reliability principles to investigate events and even event reports, closing the loop so people are more likely to report again when they know we're doing something about it. They're more likely to speak up. So that is ongoing conversations all throughout the year. In 2024, our peer support response time was averaging 45 minutes. Our goal was an hour. But because we have a really robust team who are really, really engaged, we can do it in 45 minutes. And I would guess currently we're probably less than that. It's probably more like 30 minutes from the time we hear about an event to deploying a peer supporter to contact with that staff member. So that's really very great. We're sending staff to various education opportunities. We just had a group in Palm Springs at a workshop. We have online training, things like that throughout the year. BETA comes out in April and does a validation survey where they sit with us, look at our documentation, policies, walk through a few events that we've had, they've helped us with to see if we've met their guidelines. And we achieve validation in all 5 domains for the 6th year in a row. And that is a cost savings to the organization of about $175,000. So it is what's good for the patients, what's good for the staff, and it's great for our bottom line. So we appreciate all of that. SCORE survey, culture of safety survey, everybody's favorite topic. You either love it or you hate it. This is a survey that is administered in February, March of each year. This year was the full survey, meaning it's 65 questions on a bunch of different drivers of culture or safety culture. Last year, we did an abbreviated pulse survey, so that was only 14 questions. So you'll notice on some of these graphs I'm about to show, 2024 is missing because unfortunately, due to the nature of how the survey was given, it is not apples to apples. So the survey doesn't calculate the right way. So most of these things are comparing to the last full survey we did in 2023. So we still had over 1,000 people respond this year, even though it was a full, long survey. The 74% response rate dropped just a couple of percentage points from 76 last year, and we did get some feedback that there was survey fatigue, so that is something we're very cognizant of. Excuse me, notable insights. So every department gets their top 3 strengths and their top 3 opportunities. So the organization has some very interesting strengths and opportunities this year. Our strengths are kind of that self-care. Like, we're really good at eating balanced meals, not missing meal breaks, and sleeping at night. So that, I'll take it. Cultural opportunities are related to burnout. So we'll see in the next slide when it's coming up. Burnout is still an issue, not unique to us, but recovering quickly after difficulties, mood recovering after frustrations, maintaining a positive outlook. So here are our high-level summaries of each of those drivers of culture. So green is good, red is not good, yellow is neutral. As you can see, our areas for opportunity are the burnout climate and teamwork. Every organization that takes the SCORE survey is low on burnout and teamwork. So we are working actively to improve those scores. They are moving up slowly. You can see maybe, especially for those of you who have a screen in front of you, those tiny little percentages were underneath the word positive. you'll see arrows up or down. That's the percentage change since the previous survey. In this sample size, 2% is considered a significant change. So I'm looking at burnout climate, we're at 38%, but we did improve by 4%. So that is a significant change. It doesn't feel like it when you're burned out, but it is moving in the right direction. But then you look at teamwork. There's a few different categories for teamwork. Speaking up when you see a problem, dealing with difficult colleagues, communication. We do have some room to improve there. That did drop. So these are things I think to think about as we're moving towards that true north and all of these future goals. We kind of have to keep some of these things in mind, I think, as we do all that. I just grabbed a few historical comparisons just to see how things are changing over time. Safety climate is ultimately what it comes down to is, do I feel safe bringing my family here? Do I want to be a patient here? So we are exactly the same as we were last survey. We've kind of been hovering in the same area for the last number of years. Obviously, we want that to go up. Higher is better in this situation, but, we're maintaining, and that counts for something as well. Improvement readiness, this is if I speak up, somebody will listen to me and do something about my concerns. We want people to feel like they can speak up and feel heard. So again, we're kind of hovering in the same area, which is great. I would like to see it higher, but again, anything really over 60 is good. Emotional thriving, historical comparison. Higher is better here. We are thriving. We went up 4 percentage points here, so that is fantastic. This is one of those we're at we're higher than pre-pandemic levels. I think the next one with burnout, lower is better here. We are back to that 2019 percentage. So lower is better here. So, we're moving in the right direction with burnout. Work-life balance, that's better. That's the highest it's been since we've taken the SCORE survey. So green, higher is better there. So that looks great. A couple of opportunities for improvement include local leadership. So you're thinking of the person you report to and the person they report to. Like, are we giving and receiving feedback? Do I feel heard when I speak up? We have some room for improvement there. We are definitely in our debriefings, which I'll talk about in a moment, are trying to target in specific departments that have a lot of opportunity for improvement, like some things to work on for the next year in these areas. Same with teamwork. Teamwork, some people are doing really great. Some people have some room for improvement. We're lower here than we have been in some time. This again, I think goes down to the communication. Communication we've identified is a really big opportunity for improvement. We have started a workshop, like literally starting next week, to address issues with communication, not just between your own team, but how teams communicate together. So next steps. All the departments got their reports back in May of this year. Debriefings, for those who aren't familiar with the concept of debriefings, it is where leaders will meet with their teams to talk about results, kind of see, like, do you really feel this way? I answered this way in a survey. Is this how we all perceive the culture? And work with those groups to identify 2 to 3 opportunities to work on for the year. There are certain departments that have either significantly lower scores than last time or big drops that we've done some targeted debriefings with myself and another neutral party, have gone in without the leaders present to get real honest feedback to find out, like, exactly, kind of see if we can identify some causes to come back to the leaders. There are definitely some trends that kind of goes back to that communication piece for sure. I think with that workshop that they're planning and working, I'm optimistic that will also help address some of those other areas. Like when we're communicating better, our leadership scores will go up, our teamwork scores will go up, our burnout will hopefully go down because we're able to work better together. So I think when they came to me and asked about trends and debriefings, I said, this would be like a really good one. So I'm glad you're working on it. So these items are tracked on dashboards and in performance improvement boards in the departments and through our performance improvement committee throughout the year. For our department, Janet and my department, some action items that we are owning to help improve the process next time. Getting the SCORE survey results, it's not always easy to hear. So we've tried to be proactive with peer support when those results go out, because it is really hard when you don't see the results you want. I think next year we're going to be even more proactive with that. Next year will be another shortened version of that survey, so we'll see how that goes. It's mostly just to check on those high touch point items. We are expanding our peer support team to add more medical staff members, clinicians, so we're actively recruiting physicians and APPs to join that team. I know there was a few in the room here earlier. I don't know if they're still here. We talked about that wellness burnout workshop has kind of turned into a communication workshop since I've put those slides together. But like I said, I'm optimistic that will help a lot of different areas. We also have this great new peer support module that we implemented in June, which everything is requested online through our intranet, and that really helps us not only speed up the deployment of peer support, but also track and trend how we're using it, who's using it, so we can really tailor our education to the team to better support our organization. Because I think it really, we started that peer support team right before the pandemic, and so we kind of trial by fire immediately, and it's really grown so much in the last few years that having this tool is really going to help us kind of move to the next level. And that's it. I'm a lot quicker than those other ones. Does anybody have questions?
Yeah, I've got a question if I could. It's kind of amazing to me to see some of the scores as low as they are, burnout at 47 and others as low as they are, and yet our patient satisfaction is so high and all other quality measures are so high. How do you understand the juxtaposition of those? It doesn't make sense to me, and I'm wondering if it makes sense to you. And do you benchmark against other hospitals? Is there a way to see? Is this common to have low scores in these particular areas? And then.
Yeah, I haven't benchmarked against the patient satisfaction scores, but that's something we could actually absolutely look at. I have found with my experience doing these debriefings that these people love their jobs. They love taking care of this community. They really are proud of what they do, and it really shows. And they're really good at kind of separating maybe interpersonal conflict or other concerns while they're taking care of their patients, and then they come back into a staff meeting and maybe
let loose.
Let it all out.
Yeah, right.
So I don't know how people are able to separate the two. Like I said, I see it and I commend them because their priority is their patients and they really advocate for their patients. So if they feel like they're not being heard or something's not safe, they let everybody know. And sometimes that kind of disrupts that other piece.
Yeah.
Well, I think it was
Van
also.
Gelder, Director of Quality and Regulations. I just want to respond. Burnout is a national crisis.
Yeah.
And the data that Ashley shared is there's 50 other hospitals that participate. So we are able to benchmark among those hospitals that participate in this particular survey as well.
Mm-hmm.
But it is a national challenge.
Okay, so we're not much different.
We're not unique, unfortunately.
In that way.
Okay. On the burnout, the numbers are pretty the same. When you look at the life balance, because we always sort of associated them, if you had an off-life balance, that your burnout was greater. And what we see is that the participants in the survey really had a high work-life balance, yet they had burnout. So again, there are some factors that we have to identify that add to that. Because if they're doing well with their life balance, you would think that things would be better.
There's frustrations with like technology, and I think Megan made a comment about we need to focus on the work processes we have now. So there's frustrations that people may have at work, that build over time that we need to focus on to help get past those challenges.
And we've done a lot of, you kind of have to own your burnout. Like, burnout looks different to every person. And so, yes, we can say, go on vacation, take your PTO, that's one thing, but yoga's not going to solve burnout. It's going to help your mental health, but there's definitely, it won't cause all of it, or it won't help all of it. And so, people are taking time to do, we're very much encouraging people to do all of those things. But at the same time, there's a lot that we as leaders of the organization can own. Things like giving and receiving feedback, being accountable, giving people autonomy, having them, do a job they like, encourage them to do more of what they like, things like that. So even though they're taking that time off and enjoying their lives to the fullest when they're not here, I think there's still things we could be doing to support them here in the organization. So that's a lot of questions, like, what can I do for my team? And it's like, well, they have to own some of it, but we can also do some of it.
Just a comment, I think. Well, thank you so much for showing the historical data. Thank you for this presentation. I love that. That was wonderful to see year after year where we stand. I only have one comment. It's like, as you mentioned, Jen, like, this is a national. I almost feel like I can sense you're trying to get this to go. What can we do better? I can sense it in you, and like every breath you have, but like, this is national. And so I thank you for monitoring this. I know this is part of the Beta Heart program, so thank you for doing it. I think to kind of precede from our previous discussion of our true north as we go forward, I think, as leaders, we can, lead by example. I think there's ways to help, but this is something that's national. So I appreciate the presentation. And it seems like every time I talk, Anna has something to say.
I just wanted to add to that, and thank you for the question, and thank you for the answers and the presentation. And I would say it is a national problem, and I just want to say that we know the evidence tells us that burnout rises when the supply and demand don't match, right? There's just so much demand. And even on an individual level, if you don't have enough units of service to give, it causes moral injury. The other thing I would just add is, if you know, and I know the physicians in the room know this, and anyone who's in the clinical site knows this. When you hand a prescription for insulin to somebody and you know they can't power their refrigerator, or they're going to go home and not have access to nutritious food, which we just saw is rising in this community, that causes a moral injury that is so deep. And I think that comes back to the question of the chair, what are we going to do about it? So.
Thank you.
Else from the board? No? I think historically we've gone to audience, but I think I'm going to change that to community. So any input from, we're going to use that word a lot. Any input from community?
That's one.
Are you the official counter? All right. Seeing none, this is an item for approval. So looking for a motion to approve.
I'd like to make a motion to approve the Beta Heart and Score Survey Summary Report.
I'll second.
Motion and a second. All in favor?
Aye.
Aye.
Opposed? All right. Thank you, everyone, and thank you. Ashley, did she run? Oh, there you are. Okay.
Yes.
15-4, fiscal year 2025 quality report. Janet, welcome.
Hello. More data to share. I am Janet Van Gilder, the Director of Quality and Regulations, and I'm here to share the quality dashboard for fiscal year 2025. We collect a lot of data. You just heard a lot of data. We're going to be collecting more data from our community. I think you heard from the earlier. The reason we collect so much data is so that we identify areas for improvement, opportunities for improvement. If you didn't collect data, you wouldn't know how you were doing, and so we share a lot of data with all of you. So first of all, why am I sharing this report with you? As the governing body, you're ultimately responsible. It is a CMS, which is Center for Medicaid and Medicare Services. It is a regulatory requirement that we share this information with you. The .09 number is, those are standards of ACHC. ACHC is our accrediting agency. It stands for the Accreditation Commission for Healthcare. They are deemed authorized by CMS, ACHC, to conduct our triennial accreditation surveys to make sure that our organization is compliant with the conditions of participation. And they're scheduled to come in the spring of 2026, so you'll be hearing more about that. But that aside, lots of data. So thank you to Farhad that helped pull this together. I appreciate it. We collect a wide variety of quality metrics across the health system. I'm only touching upon a few. There's much larger dashboard that the medical staff oversees within our organization, along with our clinical and nursing staff. So some of them here, just to ground you, the light blue line is the benchmark or the goal. Most of these are national benchmarks that we choose to want to obtain, of course. The dark blue line is that's how we performed for that quarter. And then the orange is the number of patient days. Some of them, lower's better, higher's better, lower's better. On 3 of these, lower is better in each. At the bottom, it describes what it is. This is our Tahoe Forest Hospital falls rate with patients with moderate or severe injuries. We've had none. Sepsis early management bundle, we were at 100% the last quarter, and we do amazingly well in this metric. The benchmark across the country is much lower, and we are far exceed that thanks to the work of our medical and clinical staff. Medicare readmissions, these are, again, Tahoe Forest, and we are well below the benchmark in this area, as well as not just Medicare, but all payer readmissions.
Janet, I can tell you in the Palisades Tahoe Ski School, our falls rate is much worse.
Yes, and with severe injuries.
So Janet, also could we in the future have information about falls that occur? Because what we're seeing are just falls that occur with injury.
Correct.
So it would be interesting, I think, also to see those falls that could have potentially had an injury, and looking at just overall falls in the hospital.
And we collect that data as well. Mm-hmm. This is the one that's reportable, so
right.
That's why, but we can add that.
You don't have, when you're presenting it to us, you could also just say that we had a total of falls, but only this many had injuries.
And we even segment it by department. So again, if you have if there's significant amount of falls, then it offers us an opportunity to improve and look at our process. So CMS Compare, we not only report our quality data on our website, which is more current, CMS Compare posts our data as well. And that's where the HCAPS that you earlier applauded and that Anna recognized, that's also posted on CMS Compare. That's our inpatient patient's perception of care. The overall quality star rating, it's based on a multitude of different quality metrics that we submit. We have not had a quality star rating since January of 2024 because we didn't meet the thresholds, volume thresholds for mortality and safety of care. So there's requirements as far as the types of patient population that the data that we submit, and so we have not had a quality star rating in, like I said, it's been 1.5 years now. Some of the other things that are posted on CMS Compare and anyone, this is a public community site that you can look up for any hospital, any home health, hospice, long-term care. They do have data, and it does show quality star rating for those organizations if you're interested in other hospitals and how they're doing. But some of the metrics that are posted there are sepsis as well as readmissions. More data. Sorry. NTSV, I always have to look this up, and I'll talk about it in a minute. It's nulliparous term singleton vertex cesarean birth rate. And I'll explain what that is. It does vary, and we'll talk about that in a moment. We also, the hospital-acquired conditions, these are a roll-up of patients that may have had deep vein thrombosis, pulmonary emboli post-surgery, or an air embolism, etc. Again, those are at 0, well below the benchmark. The expectation is 0, of course. Pressure ulcers, we are way below expected benchmarks, national benchmarks. And then patients returning to our ER within 72 hours with the same complaint. Again, the staff does an amazing job managing our patients and referring them appropriately. So NTSV I put up here more because we were slightly above expectations. What is an NTSV? It is it's the proportion of live births born beyond 37 weeks gestation to women in their first pregnancy, and it's a single baby, so no twins and triplets, etc. And they're in the vertex position, and they are delivered via cesarean birth. And the obstetricians look very closely at this data just to, again, identify opportunities for improvement. But this last quarter, we had 10 out of the 34 mothers that were delivering. 5 of them, the cephalic pelvic, so the head and the pelvis didn't jive. And so we had to proceed to a C-section. There could be changes in the baby's heart rate, which of course we need to closely monitor so that the obstetrician determined that it would be best to take the baby out sooner rather than waiting to progress through labor. There's OP presentation is, it's when they're sunny side up, and it stands for occiput posterior. I'm sorry I didn't write that in there. I realized that. It's not outpatient. It's when the baby's head is against the mom's back, but I think some of you have heard sunny side up. So there's a multitude of reasons of why we may have to proceed to cesarean section, and our physicians do a really good job to make sure we have our safe deliveries and healthy babies. A few more metrics, more data that, again, we've done really well. The Tahoe Forest SSI, surgical site infection, class 1, those are clean surgeries. Some of those that we do here could be a shoulder repair, ACLs, MCLs, hernia repairs, those types of things, most total joints. Again, we are well below benchmark in that area. Safe use of opioids, I'm going to talk about, and I know that was mentioned earlier in the presentation, is something we're focused on with our standard work bundles for the upcoming year. Patients assessed at the hospice quality measures. They had dropped down, and though they do concurrent monitoring, and we really have been at 100% for these measures as far as managing our hospice patients. And the last one is the hospital-acquired C. diff, or Clostridium difficile. Again, the staff has done a really fabulous job, in particular under the leadership of our infection preventionists, Vieta Shop, and working with our hospitals and other staff on managing that process.
If this use of opioids is safe, why is less better? I mean, it doesn't.
So, and that's the next one, and this is one of the last slides.
Sorry about that, you're right there.
So this is a new quality metric that CMS is monitoring, and a lot of it has to do with the opioid crisis. And again, we mentioned fentanyl earlier, but just across the country. It's shifted over time that we were focused on pain management and giving our patients narcotics, and then it just kind of went to the extreme, and I'm not talking just about here, I'm talking about across the country. But CMS added this metric just to help fight the opioid crisis across the country. And essentially, this is for inpatients that are 18 years or older that are prescribed 2 or more opiates upon discharge, or an opiate and a benzodiazepam. So the CMS would like us, working along with our medical staff, to limit the number of prescriptions that we're giving our patients. Not that we're not going to give them pain medication, but being very conscious and careful about mixing and matching those drugs, because it can lead to overdose and death, ultimately. So this is a new metric. We have some work to do. Our pharmacy director and the quality staff is working with our medical staff on how we can look at our workflows and our processes to help decrease appropriate prescription medications at discharge in patients.
So, Jen, I'm sorry, has the practice been across the country to provide 2 or more opioids on a discharge?
Yes, Dr. Evans.
The practice has been for many physicians to advance oral pain medications while patients are still in the hospital, to get them out of the hospital knowing that their pain is controlled on orals, as opposed to discharge them when it's kind of unclear if they're going to make it on orals. So a lot of surgeons, including some of our own, have advanced our patients on 2 oral medications, both in this opiate or benzo category. You know, CMS is concerned that you do increase the risk of an accidental overdose if you have 2 of those drugs, which is true. We have not had any problems with that, and we've been, really good at monitoring those patients. But now we have to, if we're going to comply with this metric, we're going to have to rethink the way we do this. But we don't want to have a situation where we're discharging somebody, then they end up in a lot of pain. We don't want to delay their discharges. We don't want to have readmissions. So it's a little bit of a challenging one. So we're working with our orthopedic surgeons, general surgeons, hospitalists to try to crack the code on that.
And don't they provide minimal days of medication too, in order to prevent the overdosing of it?
Absolutely, yeah. It's always going to be the least amount of pain medications necessary, but still trying to get good pain control for these post-op patients.
Yeah.
It's a challenging one. And they only just brought that measure forward, so that's why our data doesn't look so good.
We weren't able to be more proactive, which we normally are with our metrics. Last slide of data, emergency department transfer communication. This, as a critical access hospital, we monitor this. It's a requirement under the MBQIP, Medicare Beneficiary Quality Improvement Project. So for both Tahoe Forest and Incline, again, doing a great job as we transfer our patients, which we frequently need to for higher level of care, communicating the plan of care and treatment and what was done here to the physician at the receiving facility. And then nursing home compare, they Rockstar 5 out of 5 for their overall star rating for our long-term care ECC, and then home health bumped up to 4 with the benchmark being 3. So again, just a lot of great care happening here. And what questions do you have about all this data?
Janet, when I was reading this, and some childhood little ditty came to my mind, and I was thinking, when we are good, we are very, very good, and when we are bad, we're not so bad. It's still pretty good. So, congratulations. This is wonderful. It's the way my mind works. You were looking for something profound, weren't you?
You delivered, as always.
After 9 o'clock.
Yeah, it's 9 o'clock.
Alice looked like she was about to.
Oh, no.
You don't have to, I just said.
Yep.
Okay. Comments, questions?
No questions.
From our community, comments, questions? Seeing none, all right, this also is an item for approval, looking for a motion.
Motion to approve?
Second it?
Motion and a second, all in favor?
Aye.
Opposed? All right, approved 5-0, thank you. And our final item this evening for board action is a resolution to endorse Measure G for the new Truckee Library.
April, finally!
We've saved the best for last.
I thought maybe you guys were going to kick me out.
Bad choice.
Yes, I believe, Ted, you're gonna introduce.
Tee it up a little bit for you, Mr. Chairman, directors. Ted Owens, Executive Director of Governance. Before I begin, I would like to share with you all, just in case you're worried, that the spots on my face, I don't have
Anything?
chicken pox, I have a dermatologist. And so just know that it's... Yeah, please save. There we go.
You're always the one who remembers.
Okay, sorry about that. Yeah, it is. You know, before I introduce our guests, I would just like to say earlier you saw a wonderful presentation on our True North efforts. And that is really the commencement of a very large journey. And what I would like to point out to you tonight, that the folks that are with us tonight, the Friends of the Truckee Library, and I'll introduce them in just a moment, are representative of another very long journey. This actually began when I was a much younger man in my job with Nevada County. So I think we're talking 15, 16 years, something along those lines. A very long journey. They've come a long way, and we are at the cusp of success, in my judgment. And with that, what is before you tonight is a resolution to endorse the new Truckee Regional Library and Measure G, and to have that discussion. And with that, I would like very much to introduce to you April Cole, Executive Director of Friends of the Truckee Library. April, you're a rock star. Glad to have you with us here this evening. And of course, Kathleen Egan, who is a volunteer Measure G committee and a board member of the Friends of the Truckee Library, and many, many other things to this community. And with that, I'll turn it over to you.
Thank you, Ted.
Thank you, Ted.
I am well aware of that.
Welcome.
Thank you, guys. I just want to start by saying I feel incredibly grateful to have had the opportunity to come tonight of all nights. I feel informed, inspired, and grateful as a resident that gets to have a healthcare system that is so dedicated to the people in your community and really serving excellence. And I was like, this is the best night that I get to sit here and I like data. So Janet's presentation at the end, I was like, oh my gosh, I didn't know 10 out of 34 births had to go. So thank you guys. Ted really kind of teed it off. I think that synergy in looking at that very first one of the slides that I believe it was Crystal presented, and the Joseph Center being started by one person who saw a need and then brought in the community, and there was philanthropy, and then this hospital district was born, and then the hospital district grew to serve its community in what they needed then with Measure C. And I see that so much in the synergy of where we are with a hospital or a library that was built 50 years ago. In fact, I have a slide. Look at that. A library that was built 50 years ago to serve a population of 2,000 with a maximum occupancy of 54 people. And now it serves a population of 20,000 people. We have 15,000 card holders, and we still have a maximum occupancy of 54 people. Yeah. So just kind of rooting us on why we're here tonight. And I want to keep this very brief. I know you guys have had a really long night. Yeah, so we're putting that together. What I really want to focus on and share tonight is how a new Truckee Regional Library directly supports the Tahoe Forest Health Hospital District's community peak goals. Your true north. Oh, this is just great. I wish I had And really, gosh, the synergy is kind of wild. It's weird a little bit. But before the design work began, so this library, the schematic design that you guys are looking right here, Friends of the Truckee Library engaged in listening sessions. We went out and met our community where they were. We engaged with 4,000.
Only 4,000.
Only 4,000. I was like, oh. Challenge is on. Not quite there. I guess I have to go out a little bit further. Survey participants. And really, there were 5 themes that came out. And those themes were, let me just do this. I've got it here. Connection, books, space, safety, and accessibility. And really, it was that Truckee community engagement that shaped the library that we're looking to build today. And when we look at what they told us, again, I see such direct alignment with Tahoe Forest Hospital District's. I put abbreviations. I'm trying not to do that. Goals in promoting wellness, safety, and meaningful community engagement. I think meaningful is really the important word to use there. The heart of this library project is community wellness. Truly. Libraries reduce isolation, they foster belonging, and they create a safe, welcoming space for people of all ages. Actually, somebody mentioned tonight in one of the surveys that you used as far as pulling data for your community health needs assessment, your collaboration with the Community Collaborative and the Youth Forum. And that's actually data which we used as well in creating spaces. And one of the most important things that the youth said that they needed, safe and sober third places that were free and accessible. Spaces identified that would fill that need, a new library. In fact, we had our teens help us design, and this is actually a rendering of our teen center. So these are spaces, that third space that the teens were looking for. The new library will also strengthen our community safety. It will serve as an emergency resource center. So it will have permanent backup power to keep HVAC systems on in bad weather days, specifically filtration systems for heavy smoke events where people need to have clean air. We do not have a space like that available that is fully ADA accessible, has permanent backup power, and has backup power that will serve the HVAC. So this is a need in our community. The library has been designed to fill that, and we learned that need by listening to stakeholders, understanding what the gaps were in our community so that we could design efficiently and support community needs in safety as well as wellness, isolation, connection. And finally, I want to add something that I think is relevant here. The new library will expand community engagement broadly, but in direct support of your goals of meeting the community where you're at. The new Truckee Regional Library is being designed with a 300-person capacity community meeting room. And one of the things that we learned in our listening sessions is that libraries are universally acknowledged as being neutral, welcoming spaces. And because of that, the resources that are available at the library, events that happen at the library, particularly government events, health events that happen at a library, are more well attended because they are a neutral space. And so with that, I just want to say a library is a lot more than a building with books. It's a hub that strengthens wellness, safety, engagement throughout our region, and it extends the work of the hospital beyond these walls. We see this project as a real opportunity for collaboration in building a healthier, more connected Truckee. And, you know, actually I did write some notes. I wanted to say, I heard CEO Roth say, the difference between great versus good is that great knows how to get things done. So speaking of people who can get things done, I'm going to hand it over to Kathleen Egan.
Thank you, I appreciate that.
Measure G.
I'm talking about Measure G. You know, also the timeline that you had, starting with 1949. Measure G is the library's Measure C for you guys. That's it. I mean, when you look at the library that was built 50 years ago, it can only has the capacity, am I on?
You are.
Yeah, only has the capacity to really serve a very few number of people at once. So Measure G is our Measure C. And that's one of the reasons we're asking you to support it. We think there's a tremendous alignment with the interests and the community engagement and the community welfare and the health of the community. As you guys are saying it, what they answer to your question, Chair McGarry. So I think we would really like to see you endorse this Measure G for that reason. We would like to see you endorse this Measure G. You're going to put up a slide for me to actually talk about it a little bit?
Sure.
And just so you know what it is.
There it is.
So, November 4th, this November, special election, along with the redistricting, is when Measure G is going to be on the ballot. And how does it work? It's a property tax measure, different than the allocation for Measure C. It's 3 cents per building square foot. So whatever your house is, the typical house in Truckee is about 2,000 square feet. So that's $60 a year for 30 years. It's like a mortgage. You know, it's a fixed rate, no escalation, none of that, just fixed rate, boom, for 30 years. That will raise about $16 to $19 million on a net basis for construction. It's the assessing entity is the Truckee Library Joint Powers Authority, which is a combination of the town of Truckee, Nevada, and Placer County. It will cover residential and commercial conditioned units. There is a low-income exemption that's fashioned just the way Measure T was for low-income exemption. 30 years, as I said, and we need that supermajority of 66.7, which is, we all know is a really high bar to reach. It's one of the reasons also it would be really valuable to us too. So we ask really for your endorsement of Measure G. Give us that leg up too. Thank you.
Thank you.
Question, I live in Tahoe Vista. Will it be on that ballot?
It will not.
No.
The JPA boundaries go from the Donner Summit through Truckee and then into North Star and Martis Valleys.
Okay.
So right at that Martis Valley is the edge of the Placer residents that are considered in the Truckee Regional Library District.
So it doesn't include Squaw Valley or?
It does not.
Okay.
The intention is the immediate service area for the library.
Gotcha. Okay.
Actually, I have a question for General Counsel. I've supported this measure already, personally, financially. Like, is that an indication for me to vote on this?
No, that's fine. You have First Amendment right to advocate for whatever political things you want in your private time. This is simply whether or not the district will endorse this measure. The district can't spend its funds to campaign for a measure, but it does have a First Amendment right, just like you do individually, to endorse a measure like this.
So Kathleen, in April, the endorsement would be used as you're promoting Measure G.
We would let the public know that the Tahoe Forest Hospital District supports Measure G and endorses Measure G.
Have you other organizations that have come forth with an endorsement?
Truckee Donner Public Utility District in the town of Truckee for a full-on endorsement. And then the Fire District and the Rec and Park District with a support of the library project, but not a full endorsement.
Question?
No, I don't have a question. But I would like to move that we wholeheartedly endorse Measure G and the library project.
We'll get to a motion in just a second.
Thank you.
First, we'll go to our community.
Oh,
For any comments or questions?
Carrie Reed again. Thank you, Kari Rizak again, sports medicine physician. Sports medicine is a pretty small world. We brought a new athletic trainer in, and the athletic trainers all have different projects that they do to go out and reach out to the community for like BFIT in elementary schools, concussion navigation projects, the whole gambit. We had one athletic trainer who really wanted to bring in self-defense classes. She was like, I really want to do more research, want to figure this out. Like, where do I start? First thing I said was the library. So pretty much it's like initiation. Everybody has a library card in sports medicine is because it helps us support the community. So I am in wholehearted support of Measure G.
Thank you.
Hi there, Carly Fennell, I'm the Executive Director of the Foundation here at the Health System. And I have to say, fundraising is hard. April makes it look easy. It is a really difficult job. She's not a professional fundraiser by training, and I think that she has done a phenomenal job bringing this to our community. And every interaction I've ever had with her, it's just been, I mean, I think you can see it today. So I just want to say, April, you've done a phenomenal job, and it is so hard and sometimes thankless, but we thank you, and thank you very, 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 very much for what you've done to get to this point.
Thank you, Carla.
Am I red? Any other? No, just a closing comment from me then. As we consider this transformation from an incredible health system to an exceptional health system, I think it requires us to embrace a broader definition of health, right? A safe space for a high school student to go after school. That's health. Access to internet in a time of a power outage for a community member. That's health. Improving health literacy. That's health, right? So I had the opportunity to meet with this team a week ago as we were contemplating how to position this on the agenda, and it was just an incredibly inspiring conversation around the role the library can play in the health of our community, which leads to my final point, and that is, on our journey towards a true north in support of health, we will not be able to accomplish it alone. We can't, and we don't have to build every building that will support health. Every space that will support health. We've talked about others. We've had presentations by organizations such as the Kid Zone. These need to become our partners in health. It's not a journey we can tackle alone. So thank you for being here today. And with that, I will ask for a motion.
I would move that we endorse Measure G and the Truckee Library project wholeheartedly.
Wholehearted second.
Yeah, I'll wholeheartedly second it.
Not half-heartedly.
Motion
Wholeheartedly.
Motion and a second.
For
All in.
That's a motion to adopt the resolution, correct?
Yes.
Yes.
Yeah.
Thank you for clarifying. All in favor?
Aye.
Wholeheartedly.
Opposed? Approved 5-0.
What a great way to end it.
I've got to tell you guys, I thought that when Ted was talking about your long journey, he was talking about your waiting through the evening, so.
But it was inspiring, it truly was. It was truly inspiring.
Better than the last one, huh?
All right, let's close out some business here. Item 16, we had no items pulled from the consent agenda. Do you have any board committee reports?
Yes, we had the standard meeting at the Incline Village Foundation, where I gave them all the detail they needed to know about the operations of the district board.
Fantastic.
Yeah.
Thank you for that update. Director D.
I will just briefly, due to time, we have several action items that we're just currently working on, so I will not take the time that they're all in process, and I look forward to reporting next month on how we're doing.
And that's for?
That's for the Community Engagement Committee.
All right, thank you. Board member reports and closing remarks. I think we've said all that needs to be said tonight. Unless there are others that have any closing comments. And with that, we adjourn.